that's only she's being a Roman in Rome. So she'll be okay next. She comes back to the South, she'll become South Indian.
Very, very smart.
Ruchir, please let me know once you're live.
We are live now, ma'am.
Yeah, okay. Can we have the first slide, please?
Good evening, everyone.
Hi, Priyanku.
Hi, ma'am.
Hi,
Good evening.
Priyanku.
Good evening.
Okay,
Yeah.
mute.
A very warm welcome to all our esteemed faculty members and our special guests for today, Jaideep sir, Charmila madam, and Kalyan sir. It is an honor to have you all with us for the 32nd episode of the Public Awareness Committee webinars. Today, this webinar is with the South Zone Societies, and we focus today on menopausal health with our esteemed faculty speaking about hormonal therapy, genitourinary symptoms, and then we have the panel discussion on perimenopausal age group AUB. We have the experts, Dr. Ambuja madam and Dr. Shobha Gudi madam, who will be speaking on the topics.
Hello, everyone.
The panel will be moderated by Rekha madam and Sampat Kumari madam. I thank the Fogsi office bearers, Jaideep sir, Madhuri madam, for allowing us to conduct this Public Awareness Committee webinars. I now invite everyone for the inauguration ceremony. Let us evoke the blessings of Lord Almighty before we start this academic event. Ruchir, can we have the inauguration slide, please? Are you there, Ruchir? Ruchir, can you hear me? Yeah. Please start the inauguration slide so that we can move ahead. Would now like to invite Priyanka Roy, the chairperson of the Public Awareness Committee, to welcome everyone.
Good evening, everyone. It gives me immense pleasure to welcome all of you to this yet another episode of the Core Connect program. We are really happy to say that this is the 32nd program of the PSC webinar series that we have been doing over the last 2 years now. And I'm extremely thankful to our coordinators, Dr. Monica, Dr. Shatabdi, and Dr. Atulya, who have coordinated most of our programs and would not have been possible without them. I'm also thankful to our South Zone coordinators, Dr. Bharti Rajshekar ma'am and Dr. Raghavendra Prasad sir, for always helping out and, like whenever we require any help from them. We would like to, of course, thank our chief guest, Dr. Jaideep Pang sir, and our esteemed guest of honors today, Dr. Charmila and Dr. Kalyan Barmade. I'm really happy today. I mean, Monica will subsequently tell you, and we were doing this project called Tejasvi, which I'm sure most of you know about, which is regarding the bone health of women. And we have completed 1 lakh plus women whom we have tested, and Monica will talk to you about that subsequently as well. So today we have 2 excellent talks on by Dr. Ambuja and Dr. Shobha Gudi ma'am, and they're going to talk to us on where do we stand today in prescribing MHT and also genitourinary symptoms in menopause. Our esteemed chairpersons for this session are Dr. Archana Singh, Dr. Umair, and Dr. Bharti. And we have also Dr. Vijaya, Dr. Niharika, and Dr. Raghavendra Prasad sir as the chairpersons as well. To moderate the panel, we have Dr. Sampat Kumari ma'am and Dr. Rekha Rajendra Kumar ma'am. And our expert, Dr. Narsimha Reddy sir, will also join us to enlighten or to highlight his opinion regarding the AUB in perimenopausal age group. Our panelists today, Dr. Sridevi, Dr. Hemavati, Dr. Krutika, Dr. Sumaya, Dr. Amla Devi ma'am, Dr. Lalitambika, Dr. Ashish, Dr. Sujata will also be there in the discussions. So I'm extremely pleased to welcome all of you. I'm really happy that, whenever we do the South Zone webinars, actually speaking, we get the highest number of attendance as well. And that also motivates us every time when we come back to the South Zone once more, because we know that this time again it will be given a lot of encouragement and we will have a very fruitful discussion as well. So thank you so much once again for joining us. I hand over the session back to Monica and to take us forward with the blessings of our chief guest and our guest of honors.
Jaideep sir is still in a meeting. Priyankur sir is not picking up my phone.
No problem. We can start off with Charmila ma'am and Kalyan sir.
Yeah. So I would take privilege in introducing our guest of honor, Dr. Charmila madam. She has been the pillar of strength for the public awareness committees over the last 5 to 6 years. She has been always there for any book that the PSC committee also publishes. Can we have her CV, please?
Monica, it's okay.
Yeah, ma'am. Ma'am is currently the Vice President of Fogsi. Ma'am has been instrumental in quite a lot of programs from the ESAR as well as from the ICOG also. Ma'am is an active academician and she has many publications to her credit. Ma'am, we welcome you for your words of wisdom.
She's also currently the Secretary General of Justice. To add on to many more accolades that she holds and many more posts that she holds as well. And overall, as Monica has said, she has always been the backbone of the Public Awareness Committee, and she has especially been a backbone for anything that I've done apart from the Public Awareness Committee as well. So welcome you, ma'am, once more, and welcome you for your words of wisdom.
Thank you, Priyankur. I always felt that Public Awareness Committee should have come to me. I kept on asking, but I was not given the committee because I've been very close to the activities of the committee for a long time. And thank Monica for the invitation for asking me to join today. Actually, we are in Mumbai. Jaideep is extremely busy with this workshop and conference now, and that's why he's not able to join. I would like to welcome the senior most obstetricians of South Zone, Dr. Amala Devi, Dr. Ambuja, Dr. Bharati Rajashekar, the Kasoga president, Dr. Shobha Gudi madam, a very, very senior person. And I'd also like to welcome Dr. Sridevi ma'am, who's joined from Vijayawada, as well as friends from Visakhapatnam, Dr. Niharika, and I'm seeing Dr. Hemavati from Karnataka, Dr. Archana from Hyderabad, Dr. Vijaya from Chennai Society, and Dr. Sumaya, I think most of them have joined today, and it is an honor to be in a program of South Zone, especially public awareness. Just now, Monica was saying that you've crossed almost 1 lakh for your BMD testing, and you've done great work last year also, and the committee has won the Best Committee Award. That itself speaks volumes for the work that this committee has done, and I know Monica and Sadapti has done extremely good work in doing so many programs for this committee along with Priyankur. And Priyankur is a very, very I would say a great person in the way he can get things done out of anybody and everybody. And he also is a great worker, and he has done such good work for the committee. I'm happy to see Kalyan also joining. He has done such great programs in his committee work in the last years also. And I'd like to wish the committee a great webinar, good academics, as well as good social work, which should always continue. And when Monica takes over, I think it will go on to greater heights because she has been led very well by Kalyan as well as Priyankur. Thank you so much for the opportunity. All the best for the webinar.
Thank you, Shamila ma'am, for this wonderful words. It means a lot to all of us because you have always helped us in all our activities, academically and otherwise as well. Thank you, ma'am, for being here again today.
Thank you.
So
I'm going to rejoin the workshop. Bye-bye.
Sure. Thank you so much, ma'am. So next, we would like to welcome, I would like to welcome my elder brother, Dr. Kalyan Barmade. I took over the reins of this committee from Dr. Kalyan Barmade. He has been an instrumental in the Public Awareness Committee where it is today. This award that we got as the best committee, as Tamila members mentioning, is a continuation of what he has done, the work that he has done. He was instrumental in starting the Preserve the Uterus before he finished his term, and that's what we continued, and that has gone on brilliantly well as well. We have almost done 93 plus programs for that, and we have got another 7 lined up before AICOG when we finish 100 awareness programs of Preserve the Uterus across the country, all physically. Dr. Kalyan has also been instrumental in our Tejasvi project. That is a project by Torrent on bone mineral density. So he had roped in Torrent, and they also helped us a lot in this project. And we are really happy that we crossed 1 lakh plus 1 lakh plus women tested for the BMDs. Dr. Kalyan, apart from all this, is a busy practitioner. He is a secretary of IAGE, chairperson of the Infertility Committee of AMOX, and as I said, is a past chairperson and a national coordinator of the Kalyan Barmade of the Public Awareness Committee. Currently, for me, wherever I get stuck, the first phone goes to Dr. Kalyan Barmade, and that's where he stands, as I said, as an elder brother to me for anything that I do. Thank you, Dr. Kalyan, for joining. Requesting you to say a few words, please.
Thank you, Dr. Priyanku, my younger brother. Whatever work you are doing is only your work and your team's work. So I congratulate the whole team. Today, I'm very happy to join this webinar of Public Awareness Committee of the Fogsi. Can you switch the slide, please?
Please switch off the CV
stop
slide.
sharing. Stop sharing, please. Yeah.
So
Stop sharing the slide. Yeah.
Yes, I'm thankful to Dr. Jaideep Tang, Dr. Ajay Mane sir, Dr. Chamila, and all stalwarts of South Zone PSC Fogsi for joining this webinar. And I wish all the best for this webinar. I thank 2 people, that is Dr. Priyanku, Dr. Monica, and Dr. Shatabdi for working relentlessly to get where PSC committee is today. So another milestone which we everyone have done is the project which is called as Tejasvi, where across India around 104,000 women have been doing BMD at their doorsteps, and we have reports of around 50% patients have around 53% have osteopenia and around 15% have osteoporosis. So work which Public Awareness Committee is supposed to do, that is going for betterment of the women, getting them aware about their diseases, and this is a big milestone that across India around 53% have osteopenia, so that a proper diet, proper calcium supplementation, yoga, exercise, and walking is going to make their life better than what is today. So I wish all the best to the team for doing this work in Tejasvi. Also, I thank Torrent Pharma for helping us, and Fogsi team of Dr. Jaideep Tang, Dr. Ajay Man, and everybody. And I wish all the best for this webinar, and to the whole team of PSC for doing this wonderful job. You are the best people around. All the best, Dr. Monica and Dr. Shatabdi, for the future generations to come. And I'm thankful to Dr. Priyankur, because where I find Priyankur from a small Siliguri society, and he is the president material, and no doubt he'll be a Fogsi president in next 10 years. So I wish all the best to Dr. Priyankur also. Thank you so much for inviting.
Thank you, Kalyan sir, for your precious words and being the backbone for the Public Awareness Committee. We want you to please stay back to unveil the poster of this activity that we have done. Can we please share the slide? Sir, we request you and Shamala madam to please unveil this poster for the next slide. Ruchir, can we have the curtain raiser, please? The next slide. Is there any internet issue from your side?
Monica, do you have the slides with you? You want to share them?
I have it as an image. Actually, this is the next slide, please. Yeah. We have more than 104,000 women who have been tested till today, around 4:30 p.m. today. That is what Ms. Kavita has informed me. And more than 15% are osteopenic. This is what we have found out in the study of what we analyze the data that have been given to us. We're really, really thankful to Torrent Pharma for conducting this campaign along with the Public Awareness Committee. We are also thankful to Jaideep sir, Madhuri madam, Ajay sir, Kalyan sir for allowing us to conduct this presidential campaign. Over to you, Priyankar, so that we can also take some words from Kavita and Sunil who have joined us from Torrent Pharma.
No, thank you so much, Monica. I mean, so I just to reiterate what Dr. Kalyan has said. I think more than me, Dr. Kalyan will be a more appropriate person to talk about this because it was his dream and he wanted to start it. And with his mission on, we did it with the Public Awareness Committee. So, Dr. Kalyan, maybe you can say a couple of words and then we can thank Torrent Pharma and ask them to say a couple of words before moving on.
Thank you, Dr. Priyankur. This was the time when Public Awareness Committee under Dr. Priyankur got award for the more than 1 lakh HB estimation, and we were in Delhi celebrating this event. So that was the time when we decided we should do something else so that this chain continues. And what is our main purpose is betterment of the women of India, morely in the rural part where medical facilities are not available. So that's how we came across this proposal under Torrent Pharma to do bone marrow density tests at their doorsteps. And Dr. Jaideep Tank nodded for this. Dr. Ajay Mane, Dr. Charmila, Dr. Monica, Shatabdi, everybody had a positive go for us. And that's how Torrent Pharma came in, because they are already doing bone marrow activities, BMD activities across India. And that is a mammoth job they have done for PSC Fogsi. So I thank Torrent Pharma for their initiative under CSR to help us to go to the needy people across rural India and find out about what is their osteopenia status, what is their osteoporosis status, what all things are needed for them to do in the future to have a better life in the menopausal phase. So I thank Dr. Priyankur and I thank Torrent Pharma for this initiative, which has now reached 1 lakh, and we want Torrent Pharma to help us to enroll this into the Greenwich Book of Records, if possible. Thank you so much. Over to Dr. Priyank.
Yeah, thank you, Dr. Kalyan. Monica, you want to invite someone from Torrent?
May I request Mr. Sunil and Kavita Bhagwat, who have joined from Torrent, to please share your experience with the same.
Yeah, thank you so much, ma'am, Monica, ma'am. Just a minute. Shall I share the screen, ma'am?
Yes,
I have
please.
something to share.
Yes.
Yeah. Hope the slides is visible and I'm audible, Priyankur, sir.
Yes, the slides are visible and you're audible.
Yeah. So thank you so much, Team Fogsi, for giving us this opportunity of Mission Tejasvi, which we took almost 6 to 7 months back. And I still remember our first meeting, Dr. Kalyan Barmade with Dr. Priyankura, Dr. Monica ma'am, that how are we going to do this? So 1 lakh, and thank you so much for your continuous follow-up also, and your continuous push also made us to do things even better. And this step up campaign to prioritize bone health, because we all have been talking about bone health, but nobody's caring, and everyone knows that calcium intake has gone down because of that. Many other reasons, the exercise, the yoga, people are not physically active, and that's why the number of bone issues are increasing in India. And these are few of the inputs which, with the help of Fogsi, we did. This was a placard which we did, the appeal letter from Dr. Jaideep Tang himself, and also a video which also asked many gynecologists to come forward and join our campaign, and followed by a questionnaire. So these are a few of the inputs. Along with, we approached all the Fogsi member societies, and they readily accepted our invitation and helped us to conduct BMD camps across the nation. And because of that itself, I today proudly, already it has been announced by Dr. Kalyan Barmade and Dr. Monica ma'am, that we have crossed 1 lakh women BMD this screening. And just what sir said, I would like to reiterate that out of that, 7 out of those, 10 out of that 7 people have brittle bones, and this tells that almost around, just a minute, around 33% only were healthy, and around 51% had osteopenia, and that tells a volume that how much focus we all need to give on bone health, and around 16% were osteopenic, and that's why we are we will be with you, sir, to prioritize bone health among every woman, and we will continue this our mission to strengthen India in terms of bone health. And in follow-up, we also prepared this poster which we discussed with Tanks also, and then this is now there in across the nation, almost all 24,000 gynecologists, and telling that why everyone should focus on their exercise, their diet, and also take the calcium fortified food, and why calcium is important at every stage of their life. So this is what is our mission, and even a 10% increase in bone mass during their adolescence will help them to delay the osteoporosis by almost 13 years. So this is what mission we are carrying forward, sir. And we will always be with Foxy, and we will continue our quest towards ensuring that women's every stage of life is strengthened with the help of calcium and strong bones. So thank you so much, everyone, for giving us a chance, and definitely we'll see what Dr. Kalyan sir said, how we can make it into the record books. I'll try to get in touch with the authorities and get back to you, sir. Thank you so much. And this was it from our side, and from the entire team, Be Well and Torrent Pharma. Thank you so much for giving us this golden opportunity in association with Public Awareness Committee, sir. Thank you so much, sir.
Thank you, Team Torrent. I think, right, we'll move on with the academic session, right, Monica?
Yeah.
So before we
Thank
move
you
on,
so much.
I will
Yes,
just say one thing. Thank you. I would really like to thank Torrent again, Mr. Reddy, Mr. Robin, and all the whole team who has helped us in doing this whole program. Jaideep sir always says that he believes in collaboration. We always have seen collaboration between societies, between committees, etc. But I think this is the first time that we are seeing also 2 pharmaceutical companies collaborating in one program, where we see Corona. And I'm really thankful to Corona actually, because I called them in the morning to ask them if they could allow Torrent Pharma to come and present the slides as well, and they agreed, and I'm really thankful to Corona for that, and I'm thankful to Torrent as well for helping us for all that they have done, and that the support that they have that they've given us needed to be thanked. So thank you so much for being here. Monica, please, you can take away with the scientific session. Thank you so much.
Thank you, Jaideep sir, Sharmila madam, and Kalyan sir for gracing the occasion. And thank you, Torrent Pharma, for being there with us. And thank you for the initiative. We declare that the inauguration is now over, and we move forward to the scientific session. This session is by Dr. Ambuja madam, and she will be speaking about where do we stand today in prescribing the hormonal therapy. Our chairpersons for today, please can we get the next slide? Dr. Archana Singh madam, Dr. Umayal madam, and Dr. Bharti ma'am. Yeah. The next slide, Ruchir, please. Dr. Archana Singh madam is the professor and HOD of the Gynaec Medical College at Siddipet. She's also a consultant at Yashoda Hospital, Hyderabad. She's the vice president of the Society of Hyderabad. She's a brilliant academician with a gold medal at the MBBS level, and she has been awarded for many papers to her credit. She also has a national award for the best paper in geriatric gynecology in 2018 at AICOG. Her special areas of interest include high-risk obstetrics, adolescent health, and non-descent vaginal hysterectomy. We welcome you, ma'am. Our next chairperson for today.
Good evening, everyone.
Dr. Umayal, madam. She's a consultant at Sri Kumaran Specialty Hospital. She has held various positions in the IMA at Tambaram from the year 2010 to 2023. She is a founder member of the Tambaram OBGY Forum from 2013, a founder secretary of Kanchipuram OBGY Society 2019, the organizing chairperson for the annual oration of IMA Tambaram 2014 to 22. We welcome you, ma'am, to chair this session. Our next chairperson is none other than Dr. Bharti Rajshekhar, madam. She is also the South Zone coordinator for this program and for the Public Awareness Committee. We now invite Dr. Archana Madam to please introduce our speaker, Dr. Ambuja Ma'am.
Thank you for the kind introduction, and I am honored to introduce Ambuja Madam, who was not only my HOD when I joined as an assistant, but she was a mentor and guide for a long time, and she is. Can you put her CV also, ma'am? She has been professor for a long time and at the biggest hospital at Hyderabad, and she is visiting professor at Savita at present. She has been treasurer, peer reviewer, and undergraduates and postgraduate examination, and her role in menopause society is well known to everybody. So over to you, Ambuja madam.
Thank you, Archana.
Thank you.
Shall I share my
Namaste,
screen?
ma'am.
Yeah.
Namaste, ma'am.
1 minute, I'm going to start. Yeah. Good evening, everybody. And first of all, I would congratulate this Public Awareness Committee for doing a wonderful work that is doing 1 lakh BMD, which is unimaginable, really. I think it needs a great applause for that. I thank this PSC people to invite me for this South Zone conference, and I thank Dr. Jaideep Tank, President, the guest of honor, Dr. Charmila, and all my friends, Priyanku Rai, Chairperson, Public Awareness Committee, Dr. Monica, Dr. Shobha Gudi, for everybody. And to get into the topic.
Ruchir, please stop sharing your slides so that Madam can share her slides.
Why you are not able to see my slides?
Yes, ma'am. Now I can see, ma'am. Yes.
Yeah. They say I bring greetings from Hyderabad. And today's topic, where do we stand today in prescribing MHT? MHT is the subject which is really highly controversial. From the time it started, today it will say yes for something, and tomorrow it will say no again. So always we are confused where we stand for. There are some milestones which we should know. Actually, when started, hardly it is a new subject, because only since 50 years we are thinking of giving hormones. Before that, not many people lived their life in the post-productive years or post-menopausal years to complain also. And then after all, we came to know that estrogen deficiency is the cause. So that time when it was introduced, everybody was thinking it is the elixir of life. What we call in Urdu is the Jinda Talisman. If you give estrogen, everything will be solved. That was the thing it was done when Primarian was started. But later on, they came to know that endometrial cancer is the one. So combined hormone therapy has started. So this is what is the thing. And 2002, a landmark, I think all of you will remember, when WHO study, it came out saying that it is doing more harm, like myocardial infarction and cancer breast. Suddenly the graph has come down. So now we'll see where they are. The vision of International Menopause Society is all women across the world will have easy and equitable access to evidence-based knowledge and healthcare. Healthcare for women, always, MHT means it is menopause hormone therapy. We are prescribing menopausal hormone therapy only when they attain menopause. But actually, what is the thing that is happening? You see, this is the late reproductive period and menopausal transition. These are the period where FSH is increased, and so all the problems like hot flushes, symptoms, they start, and they need medicine at this point of time. So we have to change our attitude that we should treat these people also, keeping in mind that what is the cardiovascular risk or the cancer risk. Empowering them to make fully informed midlife health choices is the vision of International Menopause Society. So I told you impact how it is in 2002, it has fallen down. 32% decrease of use of MHT by 2003. they almost, I can say, only 4% of the people were using. Actually, 13 years after follow-up of the WHO study, this is the biggest randomized study that is conducted on the menopause hormone therapy, where they proved estrogens are doing much better service than anybody else. That is why it's not a contraindication, but all the havoc is because of the synthetic progesterones which we were using. So today, where we are standing, we'll see. After 15 years of WHO study, because it is published in 2002, the big concern in clinical practice is not the overuse of hormone therapy for prevention of chronic conditions. It is the underutilization and undertreatment of women who have heart pressures, night sweats, disrupted sleep, and impaired quality of life, and are otherwise appropriate candidates for the hormone therapy. So they are all denied of using this. So what happened? Everybody started doing so much of work, but they keep study, elite study, DOP study. But you know, nobody did a randomized controlled study like WHO study. That is why even today, though it is incomplete, we are taking that as the standard. And with all the developments in this, there is from 2015 onwards, it has the usage of the hormones has increased, but still we can say we are lagging so behind with this one. So in prescribing MHT, we should, the 5 Ws we should follow. What are they? One is, who is MHT for whom we have to prescribe. Very, very clear in all the guidelines, it is stated that severe vasomotor symptoms, and either it is because of the menopause or surgical menopause or natural menopause, and distressing symptoms, vulvovaginal atrophy and GSM, which our Shobhagudi is going to speak, and osteoporosis prevention. This is very important, you should remember. Never it was stated that, but now the latest guideline says, in a high-risk patient, to prevent fractures, we can use it. But otherwise, MHT is not indicated for any condition of the preventive measures, not for cardiovascular, though it is useful, not for cardiovascular disease, not for dementia, not for primary prevention of any of these things we should use. Next question comes, should women without symptoms be prescribed MHT? Always, many people will have these complaints with them. Yes, in which condition? It is in the early menopause and when premature ovarian insufficiency. But please don't use it as elixir of youth for skin condition, because I'm not having a smooth skin, hair fall is there. No, estrogens and MHT is not for that. Should medically high-risk women be prescribed MHT? Yes, we cannot deny them, but only thing is, do the risk assessment for them and then prescribe. That's what is the personalization of the thing, and medical eligibility criteria should be used. As with contraception, it should be done. It is underway, it is not ready yet. So this is what is the cardiovascular risk assessment, what we are doing. And with this, we will know whether it is a mild risk or high risk. And with this, we will decide estrogens whether to prescribe orally or transdermally, because oral estrogens, any day it has to pass through the liver and causes the, excuse me, 1 minute. Lipid profile will be damaged. That's why transdermal is much better, or you avoid if it is a high-risk patient. So we are very clear to whom we have to prescribe. But now, what type of and what doses of the hormone should be prescribed? Type of estrogen, the first WHO study, when it is there, it is with a primarin. It is a conjugated estrogen combining of so many compounds were there. That is why it was a bad effect. And what about the progesterone? It was there in WHO study. It was medroxyprogesterone acetate, which is very bad because it is a synthetic progesterone. Now it is replaced by natural progesterones and natural estrogens. What is the natural estrogens? estrone, estradiol, estriol, and the E4, that is estetrol, is the thing which are coming to the vogue and which is now made available with this. Most type of estrogens, they are all very good for the vasomotor symptoms, but the route of delivery is very, very important. That is oral versus non-oral. It is a cardiometabolic significance, and that is better in the thromboembolism or with the thromboembolic events, that is for the transdermal estrogen. Healthy women at usual age of menopause can have oral MHT if they prefer, or if they cannot absorb or are allergic to transdermal estrogen, means oral is much better. This is again a big controversy what we are having. We were thinking that transdermal is always better than oral and we can avoid so many problems. But you know what are the problems with the transdermal? Transdermal is not always the best option. Only in high risk, that is obesity or deep vein thrombosis. Why? Considerable variations are there in serum concentrations of estradiol in women treated with the same transdermal preparation. If two people are treated with the same, the estradiol serum levels are different, means large individual differences there. And the efficacy of transdermal MHT is based on permeability of the steroid through the skin, diet, alcohol, drug consumption, smoking, physical activity, stress, all has got the absorption that it changes the peripheral blood flow and absorption and metabolism is interfered. Now, can we suggest transdermal to everybody? No. It's about 10 years back, we said transdermal is better than oral. No, now we have know that absorption is not the same with two people. That is why if oral, if they cannot tolerate, or if it is contraindicated only, we will go for the transdermal. But otherwise, for a normal person, oral is the better one. What about the estradiol novel drug delivery system spray that has come? It is very costly, but see, the problem is, one is cost, it has to be used repeatedly. So still in India, we are not using, but it is good, it proved to be good. What about the type of progestogens it is there? I told you, now using the question of synthetic estrogens and progesterones is out of thing, we don't use it. So think only of the natural estrogens and progesterones. In the progesterone, we have identical type of progesterone, that is dihydrogesterone, that is similar to progesterone. And why do we use progesterone at all? Because all the problems that have come in the WHO study is only because of the progesterone, synthetic progesterone. But my dear friends, progesterone is only to protect the endometrium against hyperplasia or the carcinoma. Otherwise, it has got no role. All the problems are only because of the estrogen deficiency. Then most progesterones achieve this if used in sufficient doses and duration. You mind, this is very, very important. Suppose if it is very severe, estradiol, when we are using, we may change it to 2 milligrams. That time, we have to increase the dose of the progesterone. This is again another landmark which we should remember. It is not the fixed dose of progesterone what we should use. Suppose if we change the dose of estrogen, progesterone also should be added more. Otherwise, we should do the uterine surveillance periodically to see that there is no hyperplasia or carcinoma. What makes one more thing, what makes dihydrogesterone a unique molecule? Dihydrogesterone is highly selective for progesterone receptors, thereby decreasing the risk of adverse effects. It has got no estrogenic, no androgenic, no glucocorticoid effect. So it is better progesterone, we can use it. And second thing is, AICOG has not approved the vaginal tablets for the vasomotor symptoms, tablets that we are using as the offline only. he's Toby D. Villaris is the president of International Menopause Society in 2001. He said the risk of breast cancer is lowered with estrogen alone compared to medroxyprogesterone and CCA that is there. And addition of MPA to estrogen in patients with intact uterus attenuated the beneficial effects seen with the estrogen alone in cardiovascular problems. So don't use medroxyprogesterone for postmenopausal patients. Even now, for all the other, for COCs, that is combined hormonal contraceptives also with the natural estrogens are available. I'll show you where we can use it for the contraception. So doses of estrogen and progesterone is very important. If the dose of estrogen is increased, I already told you the dose of progesterone should also be increased to maintain the adequate endometrial protection. Because you take a, suppose when we are giving estrogen for the first half and estrogen progesterone for the second half, sequential regime we are following, we use 10 milligrams of dydrogesterone. Suppose if we use 5 milligrams, it is not enough to protect the endometrium. That is why using the progesterone equivalent to the estrogen doses is very essential. So other options, if it is not, we are not using sequential regime, means intrauterine levonorgestrel and vaginal progesterones and bezodoxepin combination, which is not available. I think all these are the off-label still. We are supposed to use only the natural estrogens and natural progesterones. Those only the 17 beta estradiol, 1 milligram or 2 milligrams, and the progesterones micronized sequential 200 milligrams, continuous 100 milligrams we are using. Dydrogesterone 10 milligrams sequential and 5 milligrams continuous. I think all of you know what this is not my thing today to explain what is sequential, what is continuous, but I am telling. Continuous is the one where both estrogens and progesterones are given from day 1 to day 28. But sequential is first half is only the estrogens, second half we are giving the estrogens plus progesterones. Always endometrial protection will be present. Minimum 10 days of progesterone should be added and maximum 14 days. Below that, if you give, it's not going to be helpful. Giving 5 days or substandard doses of 5 milligrams is not going to help. So this is very, very important to remember. So 2 points, what I told is, one is transdermal, what we are thinking is not so good, but only contraindicated for oral, we are going for transdermal. Always use natural estrogens and progesterone should be added in a sufficient dose enough to maintain the endometrium. So until now, these are the 3 changes that I have told. Next question comes, can we use combined oral contraceptives in perimenopause as MHT? So always, I told you, this is the menopause hormone therapy means we are thinking always giving it to post-menopause. But actual people who are suffering is the when perimenopause and late reproductive period, that is there where the LH is increased and estrogen levels will be going up and down. So that cases, can we give COC? COC means what? This is the synthetic estrogen, ethinyl estradiol, and synthetic progesterone are there. For a healthy young person, yes, we can use COC. Women who do not have any contraindications other than age, yes, we can use it. And newer estradiol and estriol combined oral contraceptives may have a less thromboembolic risk. So now the thing is, unmet need is newer cirrhosis. We have to see what things can be. So Is it very clear for you? Any time, many people will be asking, can we use combined contraceptives for prevention of pregnancy in the in the first year of menopause and all? Yes, if there is no contraindication, no other problems, we can use it. But we have got a better drugs which contains the estradiol and estetrol. Estetrol is E4. So we will see what are those. Estradiol valerate and Dinogus combination is now available. That is Claria. Bayer is preparing that one here. Estradiol valerate is converted into the estradiol, and so it is a better drug for absorption, and liver pressure will be less with this drug. And the next comes is the estetrol and drospirenone combination. This is also contraceptive. It is a very good combination. And estetrol is a natural estrogen from human fetal liver and is also produced synthetically from plants. It is more potent than synthetic estrogen, ethinyl estradiol, that is found in many other services. Here I want to tell you, MHT is not a contraceptive. Why? The dose of MHT is very much less, where it cannot suppress the ovulation. That is why ethinyl estradiol, which is 100 times more potent than estradiol, is used as a contraceptive. But here again, estetrol is almost equal to the ethinyl estradiol in suppressing ovulation. That is why it is a better control, and you can use it as a contraceptive. And what about the drospirenone? And compared to the synthetic progesterones that are used, this is an anti-mineralocorticoid action and is a spiral active derivative, which makes the combination more effective, maintains regular and predictable bleeding cycles, low risk of thrombosis, favorable safety profile, minimal changes in body weight, limited impact on liver function, and lipid and carbohydrate metabolism. So, as on today, this is a very good combination. Next slide, which is not available right now in India. I think in near future it's going to come. It's already people in other countries, they are using. It's going to be a very good one. I told you MHT is such a controversial subject. And by the time it comes, you don't know how many things will change. But it looks, it's a very good monitoring of MHT. Always, we should monitor how. No need to do hormonal profile. You know very well, whenever we are starting the MHT, how do we say that it is a menopause? Once 1 year menstruation is not there in a normal person, then we call it as a menopause. But if it occurs below 40 years, then we'll do all the investigations. And when we are changing the medicine, we have to do the investigation. So routine hormone therapy to start the MHT is not necessary. But only when it is not responding within 12 weeks of treatment, then we have to do the things. What about the compounded bioidentical hormones which are available everywhere, wherever you go, Ayurvedic shop, homeopathic shop, so many things are available. But maybe they are very good, but only thing is not a proper study is being done to say that it's not going to do harm. We have seen many patients having the postmenopausal bleeding because of the bioidentical hormones which they have used. What about the testosterone? Yes, it is proved that testosterone deficiency is there. It's not always, it is the estrogen deficiency that causes the problems, and the ovarian tissue produces the testosterone, and deficiency of this causes the libido and all the problems, but it is not approved. And off-label, we can use testosterone gel, 1/10 of it. And of course, we have libido oral tibolone. And again, the drawbacks, it should be used only in the postmenopausal women. But always, you see, in your practice, you would have seen many perimenopausal women will get the dryness of vagina, itching, estrogen deficiency symptoms, all these things result where it is not useful. The third question comes, when should MHD be started and stopped? For premature menopause or early menopause, yes, immediately once you see, do all the investigations and do the risk assessment and then start the hormones. For other patients, it is only symptomatic. So, for health-related quality of life and long-term health risks, osteoporosis, cardiovascular disease, dementia, we need to see for that, but not for prevention of any long-term complications. Until the usual age of menopause or personalized continuation of MHT, consider after this based on benefit risk assessment. So, risk assessment is very, very important. It is available for all the like heart, like CVS and bone marrow density and all. MHT is currently indicated for women in menopause and late perimenopause. Menopause associated symptoms often commence in, I told you, in premenopause itself. Can we start MHT in older postmenopausal women? This is another question. Can we continue after 60 years? Yes, routine initiation of MHT after 60 years. Don't start after 60. But if you are giving previously, and if the symptoms are not, once you stop, they are going to get the symptoms again. You can continue with all the precautions to see that she is not a case for either cardiovascular disease or for the venous thromboembolic complications. So it's now very clear. 60 years is not the age limit. If there are no contraindications, you can continue hormone therapy if necessary after the 60 years. Again, no MHT for prevention of any long-term complications or metabolic diseases. Persistent VMS after investigations you can do. And of course, treatment of genitourinary syndrome of menopause, Shobha will take, but there is no end for it. Even 90 years lady, we can use because the vaginal estrogens which we are using, that is, they are very, very, very sober. That is the estriol creams which we are using. They are not potent as the. Yes, I'm going to start. Give me 2 more minutes. When are we going to start? Arbitrary, there is no arbitrary time limit. Personalized approach must be there. Is menopause being over medicalized? Yes. For a normal person, don't you hormone therapy? You encourage them to lifestyle modification. I told you non-hormonal treatment we don't use. Where can MHT be accessed? Yes, these are all the helplines I wrote. And rational, this is the last slide. And primary intention is for the health-related quality of life. Do not over-medicalize menopause. Treat severe symptoms. Treat even late reproductive and perimenopausal women. Combined contraceptives with estradiol can be used if contraception required. If there is no contraindication, better option is estradiol dinogest combination or estetrol and drospirenone combination. TT is not always better option than oral, and progesterone only for endometrial protection. And one more thing what I want to tell is there are conditions where history of premenstrual syndrome and premenstrual disorders, if they are present, they are sensitive for the progesterone. So there we need to use the progesterone to a lower level. Means instead of in a sequential regime, instead of using 200 milligrams, we have to go for 100 milligrams. Then you may ask, is it going to protect endometrial hyperplasia? Yes, definitely it will not protect completely. That is why repeated surveillance of the endometrium is necessary. Whenever you use a lower doses of progesterone considered to the estrogen level. So it should be a ratio for both must be maintained. That is why primary prevention of chronic disease is through healthy eating, acting lifestyle, and prevention immunization of the things. Timely and appropriate screening and risk assessment is very, very important. This is what I just wanted to convey. What are the changes that are there? how we are going to deal with it in the present day thing that is there. And thank you all for giving such a good opportunity and listening to me very patiently. Thank you very much.
Thank you, ma'am. It was really wonderful. You have covered all the points. Only thing I wanted to ask, ma'am, there are certain patients which we come across and they have menopausal symptoms like vasomotor symptoms or a lot of hot flushes and all those things. But they also feel good when MST is started and crying spells and mood depression improves. So, this MST
This is a window of
patients are
opportunity.
handicapped
This is a
because
window
of that.
opportunity. We are not giving for dementia or mood changes MHT, but along with that one, this is going to act. That is the effect, especially the joint pains, muscle pains, mood, and all, it definitely will act. And one more thing is, they are all, whenever they are present, most of the people, they'll 80% or 90% people will have hot, cold sweats and hot flashes that will be present. And one more thing is hot flashes, many a times it is a pre-indicator for the cardiovascular problems that are going to happen. So that's how we are going to do the patients will have hot pressures for a longer time than expected. Usually it will be going away within 2 to 3 years. But if they are there in the 60s or 70s, the thing is we have to do the carotid intima media thickening by ultrasound and see how much effect is present on the cardiovascular system and how much it is going to affect. So it is a forerunner for the cardiovascular disease. Yes, Archana, what you said, definitely it is going to help. But for the sake of prevention of dementia or mood, we cannot use MHT.
Thank you, ma'am.
Thank you, Monica.
It was an excellent talk covering almost all the aspects of hormonal replacement therapy. Thank you, our chairpersons, Dr. Bharti madam, Dr. Vijay ma'am, and Dr. Mayal ma'am, Archana ma'am, to chair this session. We move forward for the next academic talk by Dr. Shobha Gudi madam because we are already late. So this topic will be genitourinary symptoms in menopause. And our chairpersons for today's session, Dr. Vijaya ma'am, Dr. Niharika ma'am, and Dr. Raghavendra sir. Dr. Vijaya madam is an HOD and professor at the ESIS Medical College Hospital, Chennai. She is also the former director Institute of OBGY at Madras Medical College, president of the Chennai OBGY Society. Her special interests include high-risk pregnancy, infertility, and laparoscopy. We welcome you, ma'am. Our next chairperson, Dr. Niharika madam. She is a consultant at Birthright by Rainbow Hospitals, Vishakhapatnam. She is the associate member of RCOG London, the secretary of the OBGYN Society 2324, member of Public Awareness Committee, and she has also received the Fogsi Achievers Award. She has contributed to various chapters, including ethical and medical legal issues in perinatal period, and in the book of Clinical Protocols in Perinatology. We welcome you, ma'am. Our next chairperson is Dr. Raghavendra Prasad, sir. He is currently an IVF consultant, and he is also the South Zone coordinator for the Public Awareness Committee. We welcome you, sir. He's a director of Sunrise Hospital, Thangad, and an executive director at ARMC IVF Mangalore. We request our chairpersons to introduce Dr. Shobha Gudi, madam.
Good evening, everyone. Dr. Vijaya here. At the outset, I'm so happy to be a part of Public Awareness Committee, and which is doing wonderfully well. Priyanko, none other than Priyanko Rai and Dr. Kalyan. And Shobha Gudi ma'am is one of my best friend. You all know about her, and especially whenever we think of PPH, Shobha Gudi ma'am comes to my mind. And she's a postgraduate examiner, and she's a HOD at Philomena Hospital, Bangalore, and she's a chairperson, Fogsi, Family Welfare Committee, and she was the president of BSOG 2018 to 19, and she's the assessor for Government of India project Lakshya, where now we are playing from ESI, and board member FPAI, and peer reviewer of Jogi and Jog RB, and she's a General Council member ICOG 2021 to 23 and 24 to 25, President Bangalore Menopausal Society 22 to 23, and chairperson.
Vijaya,
It's okay, ma'am. Let me read, ma'am. It's chairperson of contraception and reproductive health, ISOPOP 23
I
to
think I should
25.
reduce.
And she's the editor and author of various journals and lots of publications and lots of award. So happy to be a part of this webinar. Welcome, Shobha, ma'am.
Thank you, Vijaya. That's very kind of you. Is the echo stopped now? The echo is not there, no? Yeah.
No, ma'am, no.
Yeah, because it is echoing. So thank you very much, and thank you for chairing the session, Vijaya, Niharika, and Raghavendra. Thank you so much. It is really a great responsibility to speak after the former president of IMS, Ambuja Madam, but I will try to do some justice. At the outset, let me thank the dear Monica, the young champion for Public Awareness Committee, and of course Priyankur. Of course, whenever we thank chairpersons, it is understood that we are very grateful to the President, Dr. Tank, and Dr. Patel, and the South Zone Vice President Charmila also, because it is a combined effort to put up a webinar from Fogsi. So if I am audible well, because I am doing a slight circus here, my computer audio is not okay. So I am speaking on the mobile but sharing on the laptop. So in between, if there is any problem, do let me know. Yeah, so with that I'll share. And congratulations, Monica, for the wonderful, wonderful work that you guys are doing. Extremely delighted to see your performance. Very good. So I'll just share. So is my screen visible okay?
Yes, ma'am. Yes, ma'am.
Yeah, okay. So the World Health Organization today has, is very, very rightfully saying, very correctly saying that life expectancy for women is actually reaching 85 years on an average. And earlier we used to say that 30 to 35% of a woman's life is in menopause, after menopause. But today it looks like 40 to 50% of the woman's life is after the final menstrual period. And therefore, it is so important that women's health and quality of life after menopause is highly relevant, and we need to work harder to achieve. And I think that we are going to get more and more patients demanding for menopausal care. So to get across to genitourinary syndrome of menopause, which is a slightly new nomenclature, it is a chronic progressive condition of the vulvovaginal and the lower urinary tract, and it is characterized by a broad spectrum of signs and symptoms. So it's a fairly heterogeneous condition and is not going to present itself typically every time. So sometimes we have to ask leading questions to get to the correct diagnosis, and also in order to find out the entire problem, we need to be very sensitive to how to elicit history in this case. So this term was coined by the International Society for the Study of Women's Sexual Health in the North American Menopause Society. And the GSM essentially happens, the primary condition for the gynecologist so far understood was atrophic vaginitis. And this happens because of estrogen deficiency. There is no doubt about that, but it not only affects the vagina, but also the bladder, urethra, and the paravaginal connective tissues. So let us remember that it's not only the endothelium, but up to the connective tissues also, everything gets affected because of, and not only the morphologically it gets affected, but also functionally it gets affected. So that is important to understand. Quite a few neuromuscular elements also get affected. So the estrogen deficiency primarily leads to lack of collagen and of course narrowness of vagina and sexual problems, atrophic bladder and urethra, urinary incontinence and frequency. So the dysuria, recurrent UTI, urethral prolapse, ischemia of vesicle trigone, vaginal wall prolapse, all these are the things which we see when we have, just a minute. This slide has some problem in it. Let me move ahead. Yeah. So the estrogen receptors we know that they exist in the bladder, urethra, and the trigone as well. And also, everywhere in the ligaments, levatorinae, puborectal muscles. And before menopause and after menopause, there can be a lot of change. This is what I was speaking about. Let us move ahead. This is understood that estrogen has better trophicity of the epithelium, good vascularization, and better closure pressure of bladder, increased adrenergic receptors, and these properties are lost after menopause. So the receptors aid in increasing the sensory threshold when the bladder becomes distended, and the woman can hold urine with a good amount of stored urine. But when there is lack of estrogen, the sensory threshold can decrease, and decreased urethral closing will lead to urgency. So this is a typical questionnaire which we will have always in the outpatient to look at women's symptoms. And you can see that from here starts the GSM symptoms: sexual problems, bladder problems, dryness of vagina. But you can also see here the sleep problems and depressive mood and irritability and anxiety. They will also be related to this. So let us very firmly believe that it is not only the VSM which requires treatment, but GSM also requires a lot of treatment. The basic tenets of MHT, as we we understand today, is that the most effective treatment for VMS and GSM is menopause hormone therapy, right? Because it is effective in preventing osteoporosis, effective therapy, safe for VMS less than 60 and or for menopause less than 10 years. As very clearly Ambuja Madam also said, MHT should not be used in these conditions, that I'll discuss again. The symptoms of menopause vary very widely. I again said that, and the same applies for GSM, that it varies very widely. To specifically speak on GSM, topical and transdermal will also have a role. So also will oral MHT, as we see as we go along. Urogenital atrophy caused by changes in this due to decrease during menopause and causes vaginal atrophy. So topical estrogen is recommended for the treatment of GSM and recurrent UTIs. VMS is systemic ET, as we have just now learned, but there are non-estrogenic therapies also for this local problem. Lubricants, vaginal moisturizers, local ospenephine, vaginal DHEA, and laser therapy. Now, sometimes when women are on local therapy and are also having additional VMS, then systemic estrogen therapy is also indicated in suitable cases. Now, systemic estrogen therapy will also have some effect on the vaginal atrophy, But systemic estrogen therapy will not be effective in treating the bladder part of it, the recurrent UTIs, urinary incontinence, etc., for which local treatment and focus on improving vaginal health is very, very important. Now, let me just acknowledge before I go ahead any further, because the next some of the next slides are adapted from a presentation made by the former president of Dr. Shobhana Mohandas of IMS, Dr. Shobhana Mohandas, and when they conducted the CME from Pfizer, they shared the modules with us, and I found very useful information and updated evidence in her slides. So I have adapted some of the information from her, and I thank Dr. Shobhana Mohandas for that. Now, this particular slide speaks about the local estrogen formulary options. Just get familiar with some of them. This is from the NHS system, but we also have similar preparations. Estradiol 10 microgram pessaries we don't have, but we have the vaginal cream estriol. We have the vaginal gel, I think estriol gel, and we have the vaginal cream estriol, but we also have estradiol cream. Here it is not mentioned, but we have estradiol cream. Here is another list published in the International Journal of Women's Health, Volume 10, and this speaks about estradiol cream. Can you see this? We'll speak about the dosage again. So then we have the vaginal ring estradiol, which is very convenient to use, which can have a 90 days insert period. And then we have oral also, like this ospemifene, which will help vaginally. So that is how the vaginal preparations are. Let us have a look at this statutory guidance by the British Menopause Society. I picked it up because I found a very particular segment which deals only with vaginal estrogen. It's very interesting. So it says that indication is when vagina or bladder symptoms of urogenital symptoms predominate, then vaginal estrogen alone can be used, and vaginal estrogen may also be required in addition for some women taking systemic HRT. This I have already spoken. Let us come to the options, and I told you that I will speak about the dosage. Estradiol vaginal tablet, Vagifem, then the estring, which can be changed 3 monthly, estriol 0.1%, okay, creams, okay, or pessaries, and then we have tablets and creams should be used nightly for 2 weeks, 3 weeks for pessary and gel, and then twice weekly. So it can be used nightly for 2 weeks every day, and then you can make it twice weekly. Now look here, twice weekly maintenance can be continued long term, because once we stop, the symptoms will recur. Because menopause hormone therapy is more like giving crocin for paracetamol with maybe 100 times more finesse and nuancing. It is more of symptomatic treatment. It does not, actually completely correct the underlying problem, and problems can recur once we stop. So it's long-term treatment is important. Systemic absorption is minimal, and progesterones are not required, even if the uterus is intact. So I wanted to bring home this point. So the local estrogens, epithelial will mature with the estrogen therapy, and the absorption will be improved. Start therapy before there's, and the importance is that start therapy before there is irreversible atrophic changes. So don't wait for too long. As soon as women report symptoms, please start. It will really benefit, and it is possible that it will reduce the progression of the atrophy. Okay, and will arrest the changes for the time that it is being used at least. So estradiol vaginal cream 0.01%, 2 to 4 grams daily for 1 to 2 weeks, and then gradually taper to 3 times weekly. Okay, then we should have another one is conjugated estrogen cream, 0.5 to 2 gram daily intravaginally, depending on the severity, taper gradually to alternate day, and then twice weekly. So everything comes down to twice or thrice weekly, and then long term. 1 applicator full of estriol cream twice weekly for at least 6 months, for every 3 to 4 days, right? In the beginning, twice weekly, every 3 to 4 days for at least 6 months. In the beginning, it has to be every day for about 2 weeks. That sentence has been missed. How do estradiol and estriol differ? Estrogenic effects and side effects both are less with estriol. So estradiol is less available but is more potent. So let us just finish this slide there. I have already said what I wanted to say. We next come to the next problem, which is dyspareunia due to the atrophy. Okay, dyspareunia. What we have spoken for now in general is the hormone replacement therapy for vaginal problems in general. But if we look at it one by one, then there is dyspareunia when it is reported. Then, this is what will help. Non-prescription options will help. So kindly always combine the prescription and the non-prescription options. That means increased coital activity, cessation of smoking, pelvic physiotherapy, and lubricants or moisturizers, and vaginal fractional carbon dioxide laser. There's some role for local phytoestrogens, oral vitamin D, vaginal vitamin E, and probiotics also, but not proved. But these non-prescription options are very important for GSM. The prescription options are local estrogen, ospemifene, and DHA vaginal inserts. This is what is available. And then there is the intervention of non-ablative photothermal erbium YAG laser, which is also finding its place now. It is becoming increasingly popular, especially when women suffer from atrophy and incontinence. If a woman is on MHT for hot flashes, should she still take local estrogen. So 10 to 25% on MHT, oral or transdermal, will still have urogenital atrophy and symptoms. So it will have an additional benefit effect. So a double therapy is possible. For how long can we give vaginal estrogen? Well, some of the studies which have been done and some Cochrane review is available, which concludes that even after 2 years of use, there was no endometrial proliferation with vaginal estrogen. So safety profile is fairly well established. And there are other studies which say that local ultra dose low of estriol could be effective and even in overactive bladder syndrome along with atrophy for both subjective symptoms and even urodynamic parameters of storage function not affecting the voiding function. And so that studies like this, which assess the functionality, are also there. If a woman has had history of breast cancer, can we give vaginal estrogen? So available alternatives than estrogen are less effective. Nevertheless, it is important to understand that very limited evidence from randomized control trial are there. And safety effectiveness of non-hormonal treatments or ospemifene or CEBZA or local vaginal estrogen for menopausal symptoms in women after treatment for breast cancer, very few studies are there. And RCT large cohort studies are actually needed. So this is a lacuna or a gap for us, which we need to fill an RCT for this particular cohort of patients, which is not impossible because today we are looking at more number of treated cases of breast cancer. So will they be able to establish difference in breast cancer recurrence, mortality, and tumor aggression with different types of treatment? There is a lacuna. I do not know whether it will be possible to conduct such a study because it is cancer we are talking about. These are the contraindications which Madam has already said, and I think it is similar for vaginal estrogen also. So whenever there is such a history, I think we should not be. I will go ahead. Now, there are some women where the traditional insertion of vaginal cream will not be useful. For example, vestibulodynia. So vestibulodynia actually affects about 10 to 20% of women post-menopause. Very difficult history to elicit. It is very superficial dyspareunia and very, very sensitive area around the vestibule. So if there was this particular study published in the EJOG, which says that patients were instructed to apply with fingertip very small amount of gel, estriol, only on the vestibule for 3 weeks and then twice weekly for 3 months. And they found that there was improvement in this dyspareunia score. This is what is, even with light pressure, there is a lot of burning pain. Okay, so it makes sex impossible actually. So this is a description of the vulval vestibule, how it looks, and there is sympathetic parasympathetic axons, and that is why it is so sensitive. So therefore, the coital pain cannot reverse with estrogen inserted in the vagina in such cases of vestibulodynia. So please identify vestibulodynia as separate from dyspareunia, and it is insufficient to correct severe vestibular allodynia. That is why you have to apply particularly on the vestibule. In this study, the highly hydrating properties of the gel were also adequate for preventing vestibular discomfort. So whatever we apply, it has to have a good hydrating property. Vaginal lubricants can be recommended for subjective symptom improvement of dyspareunia. This grade C recommendation from the IMS guideline, and moisturizers grade A recommended. So this is something which we have to look for in the marketed preparations. Are there good vaginal lubricants available and moistures available in where we are practicing, and we must source them for our women. We should know the trade names of the preparations and we must make them available for our women. They are very ideal. So the osmolality needs to be increased, and that is the property of the lubricant. But very high osmolality can irritate the vagina, so you must look at the optimal one and provide. And actually, coconut oil is an option, but I have found a lot of infection whenever I have told them to apply coconut oil. So I prefer to use the marketed lubricants. It is comprised of water, silicone, natural oil, or a petroleum base. Okay, so that is better. The ideal lubricant the parabens can affect the mechanism of cell turnover, may result in direct association with carcinogenesis. So please look at what it contains. Increased glycerol, increased glycerin, increased candidial growth will be caused. So antibacterial agents are added to prolong the shelf life, okay? And bacterial contamination, the bactericidal nature may have an unwanted effect. So all in all, it is important to look at a very proper one where, you know, it's no paraben, no chlorhexidine, no these products. The pH is fairly acidic like natural vagina. Osmolality is 200 to 600 and the glycerol should not exceed 10%. Okay, so that is the directive by climacteric journal. So it's good to have an ideal vaginal lubricant, and we need to understand such products. Okay, so increased coital activity will improve vaginal elasticity and lubrication, and it the moisturizers act by rehydrating the mucosal tissue. And the efficacy is much longer lasting than of lubricants, and longer acting relief by changing the fluid content of the endothelium. So it goes to a deeper level. That is what we must understand, that moisturizers will enter a deeper level than just lubricants. Particularly beneficial not only for women with symptoms of VVA and GSM that cause pain, but also for women who are not necessarily active but experience day-to-day discomfort. So I think by now all of us have understood that vaginal discomfort is not always, and dryness is not always related to sex. Even without sexual excitation, also women can feel dry and uncomfortable, just like the mouth feels dry and uncomfortable when one is thirsty. So the vagina also can feel like that. All right, so this is another option where hyaluronic acid gel every 3 days, it causes improvement. So that is also an option. Please stop smoking and please increase the pelvic floor exercises. Very good examples are there when it comes to PFM, pelvic floor muscle exercises, and we must encourage them to get trained in these exercises and to perform. It really helps. Vaginal dilators have a role in some cases. This is a new preparation, actually very much used in the West, but here it is relatively new in the market. And this is a steroid hormone, of course, a pro-hormone rather, and short-term clinical trials have found improvement in GSM cases, and it locally converts to testosterone in estradiol. So it's better to, instead of testosterone, DHEAs, because a lot of testosterone is used for sexual problems in the elderly, in the developed countries, and we can use vaginal DHEAs instead of that. It has less side effects and almost no side effects. Safer alternative to vaginal ET in patients with contraindications to estrogen. So wherever we have breast cancer survivors or severe hypertensives or such, hepatic disease, etc., maybe the vaginal DHEAs is better than that. So ospemifene is a third generation SERM, selective estrogen receptor modulator, and it was in the market for some years in India. I think because of the cost, we were not able to give it to our women much, but it is an excellent, gives excellent relief for moderate to severe dyspareunia due to menopause. It acts as an agonist in the vagina and partial agonist in the uterus and in the bone, while having neutral to antagonistic effect. All right, it is 60 milligram per day orally for 12 weeks, significantly improved the severity score. So it's a very attractive option for those women who do not like to insert things into the vagina. And it acts as a selective estrogen on the vulva and vagina as well, and on a partial agonist on the uterus. So it's a beautiful drug, but a little expensive. And up to 52 weeks, it was found to be safe to the endometrium, and it favors positive bone metabolism. So all in all, it sounds very attractive. Laser therapy, the microablative carbon dioxide laser used for vaginal epithelial resurfacing. So today, a lot of demand and a lot of improvement has happened in this therapy. And what it does, it activates heat shock proteins and growth factors and increases the vascularity, collagen, and the matrix and the thickness of vaginal epithelium. And it is possible that the effect lasts for at least a few weeks, but it is unlikely that it gives permanent relief. So vaginal erbium laser is a new second generation non-ablative photothermal therapy for the treatment of GSM. Okay, so this is the technique with which it is given, and the pulses allow controlled tissue healing, safe and harmless ambulatory procedure without ablation and carbonization of the tissues. So this is a one step further. Okay, one step further. So it is very superficial, so it does not cause any visceral damage to urethra, bladder, or rectum. One thing we need to understand is that stress incontinence, urge incontinence may improve, but stress incontinence will not improve with local estrogen. And this is the SWAN study which showed as much. And we need to understand that at this point of time, it will be important to ask the urologist to take over and do some procedure for the woman. And maybe MHT can supplement, but not contribute in a major way. So non-significant increase in stress urinary incontinence in perimenopause. So we need also to understand that unless there is pelvic organ prolapse, SUI is not, specifically connected to menopause. Urge incontinence is what is connected. And then wherever we find urinary incontinence, stress or mixed incontinence, I think reduction of weight is a very important step because obesity is always associated. This is one of the last slides. This is the EPIC study in men and women where they studied the lower urinary tract symptoms of incontinence, and they found that it is much higher in women. Incontinence problem is much higher. So we can have some jokes that women always multitask and they can laugh, cough, sneeze, and pee all at the same time. And so that is looking at the lighter side of it, but it can be a very distressing symptom. So the one last word, which even I think the previous speaker was speaking about, checking the vascularity of organs in aging. So let us understand that it is not just the depletion of hormones. It is also that the aging process is going on. And if there is in later life a lot of bladder symptoms, overactive bladder, etc., then we also need to rule out cerebral pathology on MRI, where white matter hyperintensity lesions can indicate cerebral ischemia, and therefore there can be a problem with incontinence as well. So I need to activate this. I think I finished that. Yeah. So here we need to take a very important message home that MHT prescriptions is still in evolving stage, especially for practitioners. Actually, today gynecologists have become very forward looking, very progressive. They want to improve their practice. They are looking much beyond hysterectomy to afford relief to their women. And therefore, we need to become better and better in prescribing MHT. It's need of the hour. We should not let our women suffer in silence, because that is not what is her fate. Just because she is a woman, she should not suffer, because we have solutions today. So let us help her out. Thank you very much for the patient listening.
Thank you so much, Dr. Shobha, madam. As always, a very wonderful presentation. And I think you've covered everything from the definition towards what are the symptoms, how to differentiate between vestibular dyspnea, the urge incontinence and stress, which will not get relieved. And you also spoke about the latest in the field and also about non-prescriptive options. And I think I also want to reiterate that fact that we don't speak enough about it to our patients about increasing coital activity. We should take out time to talk about how we should improve their coital activity. We should actually ask leading questions, because a lot of them don't even come up with it. They'll come up with some other problems. They'll never address those things. So that is, elephant in the room kind. So we should always look at it and we should talk about it. And I think I want to know about the vaginal DHA, ma'am. Do you think it is available in India?
Yeah, I have found, once in few months, people coming and talking about it, but I'm sure it is not readily available. But let us find out more about it, and because it seems to be a very good option for some women, and I think we need to find out more about it. Yes,
ma'am. Thank you so much, and I would like to thank Dr. Monica and Dr. Priyankur and the whole PSC team for actually bringing it over. It's a very critical topic and usually not well spoken about. So thank you, PSC team, for bringing it to the audience. Thank you so much for the opportunity.
Thank you.
Thank you, Niharika ma'am. Over to you, Raghavendra sir, for your comments. Sir, you need to unmute yourself.
It was really a wonderful discussion. I'm sorry I'm not coming on video because I am inside the OT. But thank you so much for enlightening us. And we got to learn a lot of new things which we never knew was there actually. So thank you, ma'am. And
Thank you.
thank you all.
Thank you, Shobha ma'am, for accepting our invitation. Thank you, Niharika
Monica.
ma'am, Vijay ma'am, and Raghavendra sir for chairing this session. I would now request Dr. Shatabdi to take over for the next academic session.
Thank you. Thank you for the wonderful opportunity.
Thank you, Monica. Thank you, Shobha Gudi ma'am, for the wonderful talk. Thank you, Niharika ma'am and Raghavendra sir. We will now move on with our next session. The next session is a very interesting panel discussion. The topic of the panel discussion is abnormal uterine bleeding in the perimenopausal age group. We have two very dynamic moderators with us, Dr. Sampath Kumari ma'am and Dr. Rekha Rajendra Kumar ma'am. Can I have the CVs? And our expert is Dr. Narasimha Reddy sir. Dr. Sampath, can I have the CV of Dr. Sampath Kumari ma'am? Yes. Dr. Sampath Kumari ma'am is the professor and HOD at Sri Muthukumaran Medical College and Hospital and RI. She has been the vice president of Fogsi as well as a senate member of the Tamil Nadu Dr. MGR Medical University. She is the national corresponding editor of the journal, also the founding secretary of the Tamil Nadu Obs-Gynae Society. Welcome, ma'am. It's a pleasure to listen to you. Yes. Our next moderator is our very own Dr. Rekha Rajendra Kumar ma'am. Ma'am is the medical director at Miracle IVF Hospital and Chandana Hospital at Bangalore. She is a gynecologist and IVF specialist. She is practicing for the past 32 years. She is also the president of BSOG till 2025. She has been invited as faculty in more than 750 state, national and international conferences. Welcome, Rekha ma'am. So happy to have you here. Our expert is Dr. Narasimha Reddy sir. Can I have Dr. Reddy sir's slide, please? Yes. Dr. Narasimha Reddy sir is the past president of Telangana Council of Obs-Gynae Societies. He is the professor of Obs-Gynae at Pratima Institute of Medical Sciences, Karimnagar, Telangana. Welcome, sir. We have a very interesting group of panelists with us. Our first panelist is Dr. Sridevi ma'am. Ma'am is a consultant in OBGY at Sri Vijaya Maternity Hospital, Vijayawada. Also the recipient of Dr. K. Radha Krishnamurthy Medal in Community Medicine and has been a former consultant at St. Anne's Hospital at Vijayawada. Welcome, ma'am.
Thank you.
Our next panelist is Dr. Himavatri Srinivasan ma'am. Ma'am is the director of Srinivasa Healthcare and senior consultant in Department of Maternal Fetal Medicine. She has been the executive member of SNFM India and BSOG, also the life member of IMA, Fogsi, IMS and PCOS Society. Welcome, ma'am. Our next panelist is Dr. Krutika Sajjan. Dr. Krutika Sajjan is a consultant at Adya IVF Center and Ashraya Nursing Home. She has a fellowship in reproductive medicine and has presented many original articles in various journals. Welcome, Dr. Krutika. Our next panelist is Dr. Sumayya Firdaus Patel, ma'am. Dr. Sumayya Firdaus Patel, ma'am, is a consultant in OBGY for the past 28 years, medical director of the City Hospital at Belagavi, also the president of Belagavi Obs-Gynae Society and joint secretary of the Indian Menopause Society, Belgaum chapter. Welcome, Sumayya, ma'am. Our next panelist is Dr. Sujata Alagasan, ma'am. Ma'am is a professor in Obs-Gynae at Tirunelveli Medical College and Hospital. Also, the Fogsi Tirunelveli branch secretary for the past 5 years and has conducted various live Obs-Gynae workshops. Welcome, Sujata, ma'am. Our next panelist is Dr. Ashish Ben, sir. Sir is a gynecologist and laparoscopic surgeon and the medical director at Winsta Healthcare LLP, Kannur, Kerala. He is a consultant gynae laparoscopic surgeon associated with AKG Hospital, Kannur, as well as Baby Memorial Hospital, Kannur. Welcome, Dr. Ashish. Our next panelist is Dr. Lalitambika Karunakaran, ma'am. Ma'am is the professor and head of OBGY at Government Medical College, Alappuzha. Also a senior consultant at SGMM Parumala and sonologist at Athira Scans. Welcome, Lalitambika, ma'am. Our next panelist is Dr. J. Amaladevi, ma'am. Ma'am is the president of the Dindigul Obs-Gynae Society for the past 12 years. She has been the zonal chairman of Dindigul Cosmos Lions Club as well as the president of Dindigul Manaragara Tamil Sangam and Chairman of the Women's Director Wing of IMA Dindigul. Welcome, ma'am.
Thank you.
Over to you, Rekha ma'am and Sampat Kumari ma'am. Looking forward to a wonderful session.
Thank you. Thank you. I thank Dr. Monica and Priyankur and the entire team for this opportunity. And I welcome our Reddy sir and Rekha madam, my co-moderator. Now I'll start sharing my screen.
Yeah. Thank you, ma'am. I told them to share the presentation. If you want to share, you share. Otherwise, I told them to share the presentation. Meanwhile, let me thank Dr. Monica, Dr. Priyankur, and entire team of Public Awareness Committee and Sampat Kumari Madam for making me the co-moderator. Again, my thanks to all the faculties here. Dr. Ambuja and Dr. Shobha Gudi, your presentations were excellent. Thanks, my panelists, for joining us here for this panel, and let us make it a vibrant one. Thank you.
Thank you, Rekha. Shall we start?
Yes, ma'am.
All the panelists are there. Anyway, the challenges are what makes life interesting, and overcoming them is what makes life meaningful by Joshua J. Merritt. See, if a case comes, what we are going to do? We are going to the peers' observation, evidence and the guidelines, what it says, and our experience. We combine our experience with the evidence and the guidelines. Now coming with the AUB. What is the AUB? It is an intramenstrual bleeding. It can be a postcoital bleeding. It can be a frequent bleeding, prolonged bleeding, and heavy bleeding. Previously, we used to call as epimenorrhea, polymenorrhea, oligomenorrhea. Nowadays, we are not calling like that. So now we are AUB pattern. What we are doing is it can be heavy menstrual bleeding, intermenstrual bleeding, and the unpredictable bleeding. With the history itself, we can come to the conclusion. If the patient is having bleeding and the pain and the size, more size, it is adenomyosis. If it is of normal size with no complaint, we can go as hormonal. Like that, from the history itself, we can come to know what is AUB. Now we can start with Dr. Sridevi. According to that, how are we classifying according to the FIGO? Now we don't have this classification, no, regarding the epimenorrhea. The as per FIGO, how it is classified. To come
Yes,
to
ma'am.
the conclusion. Yes, Sridevi.
FIGO has classified the causes of AUB into structural and non-structural causes. The structural are denoted by PAM coin. PAM, that is polyp, adenomyosis, leiomyoma. L is for leiomyoma, M is for malignancy and hyperplasia. Coin is for non-structural causes like C for coagulopathy, O for ovulatory dysfunction, E for endometrial, and I for iatrogenic, N for not yet classified. That is the FIGO's palm coin classification of the into structural and non-structural causes.
Yes, Sri. These structural causes, most of the time we can find out with the history and the ultrasound finding, and the non-structural causes from the history. Sridevi, can you give an example for iatrogenic and not yet classified for the sake of the audience?
Yes, ma'am. Iatrogenic can be because of any use of intrauterine contraceptive devices or even anticoagulants or drugs that inhibit dopamine that affect dopamine metabolism, like antipsychotic drugs. And again, combined oral contraceptive preparations, not yet classified, can be because of AV malformations and isthmocele, etc.
Yes. So if you don't find any cause and if the patient has undergone repeated curettage, better you go with the Doppler and you can find that an AV malformation as Sridevi was telling. So if it is an AAB, what are all the consequences? It's patient related. It can be a pain, anemia, infertility, depending on the age. In our case, it is not there, and the family related is the activities will be reduced. The limitation of the normal household activities, worsening of the quality of life, economic is cost of prices, surgical procedures, and not going for the work, loss of working days. These are all our consequences. And what is the role of gynecologist? The role is evaluate the patient and come to the conclusion for diagnosis, minimalizing the attitude, and as far as possible, non-invasive treatment. Then the patient and adopting to the correct line of management. We have to give all the options and with the patient concern, the treatment which she needs. proceed.
എവിടെയെങ്കിലും വെച്ച് കൂട്ടിക്കോ എന്നിട്ട് പിന്നെ എന്റെ
I think others can mute. So now we come to the first case. I think the second and the third case will be dealt by Dr. Rekha. 40 years old female presented on day 4 of the cycle with heavy flow during the menstruation. That is for the past 2 months. The cycles are 7 to 8 days. It lasts 30 to 30 days, once in 30 to 32 days. Hemoglobin is 9 grams, vitals are stable, and weight is 85 kg. And the transvaginal scan, that is the TVS, it shows the uterus of normal size, 7.2 into 6 into 5 centimeter. The endometrium 4 millimeter measured. Bilateral ovaries appears normal. So now we will go with Dr. Hema to proceed.
Yes, ma'am. Ma'am, the patient is 40 years with prolonged heavy bleeding, and her hemoglobin is 9 grams. I think that we have to treat her symptoms with analgesics like NSAIDs and antifibrinolytics, tranexamic acid. Medical management, expectant management will be the first line of treatment for this patient. And we have to, she has also moderate anemia, hemoglobin of 9 grams. So we have to, treat anemia also. So I'll treat her. I'll put her on symptomatic, NSAIDs, and also advise her to do the scan, especially the transvaginal scan.
Yes, it is done that is the endometrial thickness.
Yeah, then endometrium is normal, ma'am. It is 4 mm. So again, this management is probably sufficient as of now.
Yes, Hema. This is the first time she is coming to you. So whatever
Yes.
40 years, only 3 months, you go with the symptomatic treatment. If you don't reduce the pain, she will get irritated. So the analgesics and antifibrinolytics, tranexamic acid, 650 milligrams, VD was started. And we counseled the patient to send to come in the next cycle if the bleeding is heavy, or she can continue. But what happened on 18th day itself, patient came with complaints of bleeding PP. And again, she had dysmenorrhea and changing 6 to 7 parts of per day. So now we have sent the patient only 10 days back. Again, she is coming back. Now she is going to Dr. Kritika. Kritika, what are you going to, how are you going to manage?
Scan picture illa now.
Kritika, if it is not there,
Ma'am, I'll get one transvaginal scan done. And see for the endometrial thickness. And according to the endometrial thickness, if it is very thick, then we'll take a biopsy through pipple, and then we'll start her on progesterone in tapering dose, and we'll wait for the biopsy report.
Yes, Kritika, as you told, in spite of the bleeding, vaginal scan was taken. Now the endometrial thickness is 13 millimeter. So we took the pipples biopsy, as you have mentioned. And we have sent the patient with the people come after with the people's report. The people's report is complex endometrial hyperplasia. You can consider it as with or without atypia. Now we will. Now the doctor has gone to Tirunelveli, Dr. Sujata, with after taking treatment. Dr. Sujata, how are you going to manage this patient with complex endometrial hyperplasia? That symptomatic treatment has been given and the progesterone has been given by Dr. Kritika. Sujata, are you there?
Yes, madam. I am here, madam.
Yes.
And now it's a complex endometrial hyperplasia. Again, we have to treat it aggressively, madam. Because her hyperplasia, we have to treat her with heavy dose of progesterone and a strict follow-up. So that we have to see whether it reverts to normal. If it is without atypia, we can give her a progesterone. With the atypia, I will prefer a hysterectomy, madam.
Do you have anything? Anyway, it is complex with or without atypia. If it makes any difference, Sujata?
Yes, madam. With the atypia, again, a family history has to be asked. And if it is also strong, then we have to go only for a hysterectomy. If it is not, then we can go for an progesterone releasing IUCD, we can think, madam.
Yes, patient if not willing for any surgical management, you can
because the strict follow-up, it is essential, which our patients may lack. Hyperplasia, we have to give a progesterone and a 3-month follow-up with a biopsy, whether it is reverting to normal. So all this, it has to be done.
Yes.
So better will be an IUCD releasing progesterone And if there is a strong family history or no proper follow-up, better will be a hysterectomy.
So now, Dr. Lalita, because this patient is not willing for intrauterine device, as Sujata was telling. So from Tirunelveli, she moved to Kannur.
So if she's not, yes, then again it depends upon whether it is with ATP or without ATPia. Without ATPia, actually.
It has with ATPia itself.
Okay, with ATPia, the problem is that there could be accompanying focus of adenocarcinoma, or it could be pre-malignant or even malignancy or endometrial in situ carcinoma. So if she's not willing for follow-up and treatment, it will be better to go for definitive treatment, hysterectomy with bilateral salpingo-oophorectomy, because there could be a focus of adenocarcinoma when the report comes as with ATPia.
Madam, if the patient is not willing for surgery, she is telling, I don't want copper-T and I don't want Mirena, I don't want hysterectomy. Do you think any other conservative procedures?
Endometrial ablation is not recommended for hyperplasia with ATPia. Because it need not be complete and further sampling may be interfered with. So endometrial hyperplasia with ATPia, ablative procedures are not recommended. She should have either Mirena or she should have a definitive treatment like hysterectomy. Conservative treatment is not recommended. Then you can give medroxyprogesterone acetate as the last choice if the patient is not willing. Either oral medroxyprogesterone acetate, high dose about 40 to 60 milligram per day continuously for 3 months, and she should come for repeat sampling. Or Depo-Provera can be given.
Yes.
If patient is not willing for definitive treatment.
You have to counsel. Yes, medroxyprogesterone should not be given during menopause. Now you had a wonderful talk by Dr. Ambuja madam. So this is the way that the treatment is going on. Amla madam, patient is coming back to you, telling that Mirena is not advised and Mirena, I don't want hysterectomy, I don't want. What will you do, madam? Amla madam, as Lalitambika madam told, RCOG guidelines also tells that endometrial ablation is not at all for hyperplasia. Whether it is with ATPia or without ATPia, as Sujata told, it can go for carcinoma cervix. Amla madam, finally, without treatment, patient is coming to you with the bleeding. How are you going to counsel?
Try to convince her, no, because of the outcoming complications of, she may go for CA endometrium, and we should, Doppler can be done, no? Doppler, when you do ordinary scanning ultrasonogram, apart from that, you can do a uterine Doppler and see whether there is increased vascularity, whether chances of endometrial cancer is there. Try to convince her, and then you, they say for this anemia and all general conditions should be improved, and the reassurance that if it is done for her, it will be better. Otherwise, suppose if she gets into other severe complications, it will be difficult for her, no?
Yes,
So that is the thing I can do.
Definitely.
When patient is the patient is resistant to your treatment, by repeated talks, or you ask her to come after a week or so and call her relatives, also tell the complications. These are the complications you will be expecting in future, so that your life may be in danger. And then sometimes if you convince her, try to convince her with all the other case histories, you can, so the nearby cases, somebody has developed, we left her alone, she came with cancer and all. That is the only thing we can do now. When the patient is not willing for any type of management, either it's a medical or IUCD is not, it's a very difficult thing, but some patients, because of the poor knowledge about the management and the complications, they may refuse. So recounseling, it's a better thing we can do, and then convince her to undergo hysterectomy or any the type of management what we have discussed, the other speakers has mentioned about.
Thank you, madam. Yes, so this endometrial ablation is not a choice. So for this patient, since not willing for IUCD, you have to counsel for hysterectomy. As per RCOG, the atypical hyperplasia with or without ATPia, it may go for endometrial carcinoma and persistence of bleeding symptoms, and the patient who will not come for follow-up and who undergo endometrial surveillance, hysterectomy is the management of treatment. Sumaya, madam, do you have any effect with this ormeloxifene in this type of patients? Would you like to, the patient is not now, we are counseling and doing hysterectomy. If the patient not willing, Do you have any experience with armiloxifene for AUB in reproductive age group?
Yes, ma'am. Armiloxifene does reduce bleeding. It blocks the estrogen receptors in the endometrium competitively, and it also causes prolonged use causes depletion of the endometrial receptors. So there is a relief from bleeding in these patients. And also armiloxifene does not have any progestational anti-androgenic or androgenic effects. So it can be tried in these patients because she has refused other forms of treatment. Although for hyperplasia, then we have to call her for regular at least 6 monthly endometrial biopsy to rule out progression to malignancy.
Yes, for this case, since she is more
Shall I tell?
in spite of our call. Yes, madam, Ambuja, madam.
Yeah, I use a lot of armiloxifene.
Yes, I was about to come to you only, madam. Next,
So, armiloxifene can be given instead of giving some placebos. You can use the drug which is effective in some patients.
Yes,
in
ma'am.
most of the because it is very harmless. It is not cardiotoxic. But it gives some results. So better you can try it when the patient is not in for other medication, allopathic drugs sometimes. This armiloxifene also helps in some earlier days we were using it right and left, but nowadays only we had because of the newer drugs we had withdraw from the armiloxifene.
Ambuja, madam.
Yes, 60 milligrams BD twice a week. 60 milligrams twice a week for 12 weeks, and then 60 milligrams once a week for 12 weeks.
Yes,
most of the times this comes down. Only drawback what I observed is they have the ovarian cysts about 3 or 4 centimeters size. It persists for 3 months. That we should be very careful, because many a time they will go around the doctor. Somebody will say that you developed ovarian cysts, is going to become cancer and all. So we should explain them this is going to happen. And one more problem with these things is developing the DVT. That is there, but I have not come across developing DVT, because I have right now 25 cases with me which I have treated with the armiloxifene, but it is a wonderful drug. They almost will go in for amenorrhea, but again, it in the quotations, it is not FDA approved.
Yes, that is the no evidence. It is not FDA.
One thing we can say, this Saheli oral contraceptive, which government of India is promoting, is nothing but armiloxifene. When it is promoting for 2 years, but that's the dose of 30 milligrams.
For 2 years, many years as contraceptive, many years.
Yeah, many years it is for contraceptive, it is there. But still FDA has not approved this for the DUB, but in India, I think many of us are using. And it's a good result also.
So if patient is not willing for anything, as madam told, you can go with armiloxifene, 60 milligram twice a week for 12 weeks and 60 milligram once a week for 12 weeks. But you have to follow with the endometrium, and most of the time they may go for menopause. Thank you.
It is also a powerful antioxidants activity, and anti-estrogenic activity is also there. So it acts as an insulin sensitizer, so good source of omega fatty acids also. So for all these reasons, you can give this drug.
So we have sent this patient with armiloxifene only, and we have to.
Shall I add one more?
Yes, madam.
Yeah. About the atypical hyperplasia, I had a case. She refused to undergo hysterectomy because she's newly married, and of course she was 40 years old. That time, magistral acetate. The Cancer Institute from Chennai, they started with the magistral acetate for this patient. Very high dose of progesterone. So of course, later on she continued this progesterone and she developed full-fledged carcinoma. That's a big. But magistral acetate also they are advising.
So follow-up is very, very important. We should not leave it with the armiloxifene alone. Narasimha Reddy sir, are you there? I want your expert, and we'll go to the next case.
Sir had written expressing his inability to join, no, madam, in the group.
Okay, but he told that tomorrow something. Anyway, Rekha, you go with the second case. For this patient, now we have given
and Sampath. I am sitting as an expert now.
Yes, madam. Yeah.
Not the
Fine.
expert,
Very good.
definitely not
Very good.
expert, but I
Yes.
thought he is there. No problem. Later,
Yes,
we
madam.
can go with the second case.
I'm very happy to take Ambuja madam as expert, as you have given a good opinion about ormeloxifene.
Uninvited
Please,
expert.
yeah, please keep opining in these further cases also. Thank you, Sampath madam. You did great job. We move on to the second case. Dear panelists, we have totally 3 cases. One is over. I'm dealing with the second and the third case. Coming to the second case, the history would go like this. She's a 46-year-old woman with a heavy and painful periods for the last 2 years. 46-year-old. Cycles are about 5 to 6 days, once in 18 to 23 days. Little early. Hemoglobin is 9, vital stable, weight 70. The transvaginal sonography showed uterus was uniformly enlarged. It's to the extent of 10 by 7 by 6 centimeters, little bigger than what you expect normally. Myometrium showed a moderate appearance, a homogeneous texture, and had small cystic spaces within the myometrium. The endometrium was shaggy. The myoendometrial junction was shaggy, indistinct stripe, and 9 millimeter. The right ovary showed a small hemorrhagic cyst, looked like hemorrhagic cyst, and otherwise other adenexa and rest of the things were all normal. This case, okay. So, madam, can you move on? Ha, fine. Thank you so much. I would go to Dr. Sridevi.
Yes,
Dr.
ma'am.
Sridevi, with this presentation and the sonography report, what
Yes,
would strike your mind as the first diagnosis? Dr.
Most
Sridevi.
probably, ma'am, most probably it is a case of, according to the history and also the sonographic findings, it must be a
Yeah.
case of adenomyosis.
Yeah.
Adenomyosis
You see
previously,
there? Huh.
ma'am,
Yes, tell me.
adenomyosis previously it was only a histopathological diagnosis, but now non-invasive techniques like ultrasound and MRI are helping to diagnose adenomyosis before only. Like nowadays, morphological uterine sonographic assessment, there are criteria like having cystic spaces in the myometrium, asymmetrical myometrial thickness, loss of endomyometrial and endometrium and myometrial junction, etc. And also that Venetian blind sign and all those help in the diagnosis of adenomyosis. And
and it
MRI
is
helps
also
in distinction between to distinguish between adenomyoma and a fibroid also.
Yeah, most of the times it is the posterior myometrium compared to the anterior myometrium, and is that fan shaped, whatever you explained, all those things are seen. Yeah, thank you. We proceeded. We had a
Rekha,
yes, Ambuja.
Lalitambika is a very good sonologist, and she will be able to explain this. Lalita.
Fine, fine. Yeah. Lalita madam, can I have your inputs in that case?
Yeah. Regarding adenomyosis, so actually I had a phone call. What is the
We are
question,
talking
madam?
about the ultrasound picture and ultrasound diagnosis of adenomyosis here at
Yeah,
this
already
juncture.
you have given everything in the slide. One important point is asymmetrical thickening of the myometrium will be there. Here it is seen.
Yeah.
Endometrium is not
Yeah.
actually in the center. It is displaced. Usually, posterior wall will be asymmetrical. Vertical fan-shaped shadowing, small cystic spaces. Endomyometrial junction is indistinct. That is very one important thing. So it's not due to malignancy, but even in benign condition, you will find endomyometrial junction is indistinct. So these are some of the, in addition to the points mentioned earlier, these are things that will tell us about adenomyosis.
Yes, madam. We mentioned all these points. Thank you. The endometrial aspirate showed the secretory endometrium. And the question next goes to Dr. Ashish. Can I have Dr. Ashish there? Dr. Ashish, if you are there, please acknowledge your presence.
Yes.
Yeah,
Yes.
thank you so much. Sir, clinically, we made a diagnosis of, with ultrasound help, we made a diagnosis of adenomyosis. What else will you do? And in the previous slide, can I have?
Yes,
Okay.
the ultrasound has given us a diagnosis of adenomyosis, which is quite common, the same sitting with heavy menstrual bleeding, dysmenorrhea,
Next slide,
and the same symptoms in the perimenopausal age group. And we see a lot of cases of adenomyosis. Probably medical treatment first
Next
option.
slide, madam.
We have to give them symptomatic management So we have to assess how severe the patient's severe symptom is, how much of quality of life compromise she has got with the symptoms. We have to reassure the patient again that adenomyosis, nowadays people, whatever diagnosis is there on the ultrasound, they all think that they think that it's all cancer. So we have to tell them that adenomyosis is not cancerous, probably, means we have to reassure them. We have to give them medical management. We can give them painkillers. We can give them hormonal options. We can put them on oral contraceptive pills, probably, that improves their symptoms. We have to advise them regarding various treatment options available, like GnRH again is like intrauterine device, Mirena, LNG, IUS. So these are the various the things, ways in which we'll go about this with this patient. And if everything fails, if nothing works out and still she's very symptomatic, it's not the image which actually decides the treatment. It's how severe or how much of quality of life compromise that particular patient has. It is that which guides our treatment protocol or treatment modality.
Yeah. So the main thing that decides here depends on the counseling of the patient, the age of the patient, her symptoms. Especially, they're very much incapacitated with their dysmenorrhea. It is just before the periods and continues for longer number of days and losing number of days. So we have to decide on their symptoms, inability to work, as well as the fertility aspect. So many aspects we counsel on that. And as you said, we come to the management part of it. Can I go to Dr. Sumaya, madam? Madam, can you tell about the role and the help, the involvement? How do we use the LNG in these cases, in this particular patient?
Yes.
Sumaya, madam, do you advise the LNG
yes.
IUS for this 46-year-old woman, and how will you go about?
Yeah, even in a 46-year-old, I would still use LNG IUS as a first line of treatment. And of course, if she is not willing, then maybe medical management with this COC. No, I don't use contraceptive in 46-year-old, of course. We can we can go for hysterectomy if she is 46-year-old. If the symptoms are very severe, analgesics are not giving her relief, we can then go for a hysterectomy, vaginal or abdominal.
But 1 minute, Dr. Hemati, I'll come to you. All of us at this point probably agree that in this woman, if she is agreeing to the LNG, that would be the best one for her, isn't it? Because you don't need any maintenance for that. Yeah, Dr. Hemati, you want to tell us something?
As Fogsi CGPR guideline says, at above 40 years, this is the AUBA, as per POMCOIN classification, first line management would be the LNG IUS.
Yes, exactly. That's what I was telling. In this patient,
hesitancy, even 46 years, we can go ahead with the LNG IUS.
Yes, because this webinar says, especially the PAC, always the committee says that preserve the uterus is one of their
Save the
motto.
uterus.
And the patient is good with no symptoms, symptoms are much relieved, no surgery, what else she wants. That too, the LNG is minimum maintenance, what's required there. Okay, I'll come back to you, Dr. Hemawati. She's from Bangalore. Dr. Hemawati is very much associated with many of our programs. Now coming to the minimal invasive measures, the slide explains everything. Can you just tell us about what are all things that you can think of? We have spoken about the medical treatment. We have spoken about the LNG treatment. What else can you think of? The surgical part of the laparoscopy, whatever you want to say, is a minimal invasive surgery role in this patient, especially if it is a well-focused and well-contained adenomyoma.
Yes, ma'am. As we focus on, save the uterus, that's our motto. So we can try minimally invasive treatment for the adenomyosis. As you said, it is well focused. So we can remove only that part. The excisional adenomyomectomy can be done, or the debulking, remove only the visible pathological part of the uterus. So adenomyomectomy can be done for this patient.
Yeah, and the different invasive measures also they have mentioned here, like the laparoscopy, the hysteroscopy, all that. And all the more we delineate the lesion with our investigations like the ultrasound, and the MRI, Doppler are more helpful for us to exactly delineate which part of the adenomyoma.
Madam, we can also try.
Can I have?
Dr. Sujata is telling something. Yes, Sujata?
Madam, we can also try, she's having a hemorrhagic cyst. So we can also try Dynogest or now the newer drug, no, madam, Elagolix.
Elagolix, yeah.
We can also try Dynogest for 3 to 6 months.
Yeah. Medical measures we have spoken.
And also
now we have to come to the surgical measure.
Also can be tried.
Medical, I didn't mention Dynogest, Rekha. That's the reason.
Who is speaking?
Dr. Sujata. Dynogest.
Madam, Elagolix
Dr.
also can
Sujata's-
be tried, no, ma'am? Elagolix also can be tried, no? That
yes.
is orally acting GNRH analog. That also can be tried, no?
Yes,
It is
ma'am.
available.
GNRH can be tried for this patient.
Yeah, GNRH.
Another
Orally
thing.
available GNRH analog.
Yes.
Elagolix.
Yes, that can
Is
be
available in India now.
Yes, you are very much right.
Rekha is back. Yes, Rekha.
Because locally excision procedure at 46 years, I think it can also lead to additions. So
Sometimes it may not remove
Overlapping of
complete
voice.
pathology.
The
No, ma'am.
coming to the-
We can go ahead with that also.
So most of the panelists don't want to go for this.
Minimally invasive.
46 years adenomyomectomy may not work. She will continue to
ma'am.
have symptoms.
Yes.
Not even conservative surgery, ma'am. Better medical treatment.
Medical
Even if
And
she is
along
a-
with GNRH, we can do the add-back therapy also because
add-on
considering
therapy,
the effect, add-on therapy with low-dose estrogen and progesterone for 6 months.
yes, ma'am. If she is refusing LNG IUS, we can try GNRH.
GNRH.
Induce the necrosis. Like we don't want to.
Any one of you want to go with this HIFU?
Madam, can we have the picture there?
Yes, ma'am.
The
Yes, ma'am.
details of HIFU.
Yes. HIFU is okay.
The panelists.
Yes, ma'am. Yes, HIFU, if it is available, we can go, provided the distance is not more than 12 centimeters from the anterior abdominal wall, that uterus and all that. She's not obese. And we must counsel that she might require more sittings also, comfortable.
Yes, like she may need.
Rekha, ma'am, you are...
yeah.
The HIFU is costly.
Very
So
costly.
affordability of the patient is also very, very important. 20 minutes.
All the different things have to be made.
Rekha, ma'am,
Complete
is,
and it may recur or
No.
eradicate. So there is some chance of.
So Rekha, you are not clear as per the panelist, the medical management or hysterectomy only. No conservative management.
Madam, any role of 3D ultrasound or elastography, now newer things are coming.
Next slide.
For adenomyosis.
Is it available here? Sujata?
No, madam.
I don't think it is available. No, it is not available.
In our place. If available, we can go
There
with
is no, you can just mention the products, but it is not, not available. We can't use it now. Theoretically, you can speak about it.
Available, but
Only practical things, what we are using, how to manage this patient with 46 years and severe. If it is severe and that symptoms are not being relieved by your medical management, better go for hysterectomy. Just because we have got the thing that where nobody is going to remove the uterus unless it is very much indicated. It is troublesome for the patient as well as for the relatives also. Every time when she wants to come to the gynecologist for treatment, the expenses will be going higher and higher only, no? So better we can.
And at 46 years of age, I think hysterectomy is better than conservative.
Yeah, but still she is not totally 55 something. So at the age of 46, it is not the complete menopause kind of age. So especially in this medico-legal era, we have to counsel her everything, whatever measures we have for conserving the uterus, whether it is HIFU, whether it is embolization of the uterine artery, it is up to the patient to select because the choice has to be kept in front of her. So this should be our policy, not directly think of hysterectomy in this case.
No, to start with, we are not going to tell the patient that we are going to do hysterectomy for you. As you all mentioned,
yes, madam.
You keep all the modalities available in front of her. So in a hotel, if you want to
Yes,
take
madam.
dosa, you can take dosa, or you can have buri or chapati like that. So what are the treatments available? So you tell
Exactly.
her this is the cost of this. Then how much
Yes.
it will, how long you have to proceed getting medical management? You have to wait for 6 months or 3 months, and then you come up in between. You have the checkups. If you are relieved, you are comfortable with your body as mind. You know, you this is convincing the patient. Mental health is also more important. So every time you have to be so friendly, tell all the modalities available for you and cost everything. Otherwise, nowadays the practicing gynecologists face lot of problems, because when you take the uterus also, you will be sued, and if you are not taking the uterus also, you will be sued in the court.
Yes, madam.
Yes, madam. We have to explain about the pros and cons, about the cost, recurrence, everything, as you have mentioned, including the complications. Thank you, Kamla madam, for the final word on that. Now coming to the Fogsi GCPR, madam, the previous slide. Yeah, so for the polyp, it is a very clear, like a hysteroscopic surgical removal. But if it's a multiple polyp, make a diagnosis of whether it's a chronic endometritis or secondary to the endometrial hyperplasia, and also think of the fertility issue of the patient. If not interested in fertility, the LNG IUCD. In adenomyosis, all what we have mentioned, but they say that LNG is the first choice. If the patient doesn't want the LNG, then think of all other medical methods which we have already mentioned, and hysterectomy would be the last choice. So this is what we have discussed, the Fogsi GCPR. Next slide, please. Yeah, somebody can summarize on that, or you're clear on that, the summary of that slide, like we are going to.
Somebody has told about it.
Okay. Now, what is the add back therapy in this case? Is the estrogens and the low dose progesterone, etc. But many of us are not in favor of low dose estrogen at this age of 46 and all that. So this always stands as the last resort. Most of us don't think of this combination of treatment for that kind of patient of adenomyosis. I hope you all agree with this on this. So, okay, we move on to the third case.
Yes, if this the take-home message is, you go with the medical management, LNG, IUS. If not accepting and patient is not for conservative, you can go for the hysterectomy.
Hysterectomy, yes. Medical treatment, LNG, hysterectomy. So these three blocks. Okay, so I now ask these questions to Dr. Kritika Sajjan, the young gynecologist here as a panelist. Dr. Kritika, Mrs. B, she is younger than the previous patient, 39-year-old.
You didn't get the opinion
Slides
of
are not seen.
expert.
Slides are not seen.
Ambuja madam has given her opinion, but I thought I'll ask at the end slide.
Yes, slide.
Ambuja madam, you
Slides are
something
not
here?
seen. Can everybody see the slide? Slide
No,
sharing not
no.
happening.
We are not able to see the slides.
Oh, what happened? I am able to see.
Even
Yeah,
my
yeah.
face.
Slides are visible.
Slide sharing.
Even I am not seeing my face. So I can't
Slides
see
are
the
visible.
slide also.
I can see the slides, ma'am. Slides are
Nobody
visible.
can see the slide.
I can see the slides.
Some are able to see, some are not able to see.
No, I think majority are not able to see. Please share the slide.
Madam Lalitambike, madam, I am sharing the slide only.
I can
But
see, madam.
can others see? I can't see. Since
No,
a
you
few
go to
slides I'm
your,
not seeing.
madam, you go to your grid window.
Grid view must be
Lalitambika, madam.
changed, ma'am.
The
What
view.
window?
Go to your
maybe
view
grid
window. View window.
Yes, yes.
Okay,
Madam,
okay.
probably I've changed the window, that's why.
Yeah.
Maybe.
View, you have to take the view option in that. Yeah.
Right side top corner, ma'am.
Okay, I'll see.
Okay. So, madam,
Not
we
seen
side by
anyway,
side
I'll try.
speaker.
Fine. Okay. Shall we move on to the third case?
Yes, ma'am.
Dr. Kritika, she is a 39-year-old lady who has 2 living children. Both were by cesarean. Now she has menorrhagia as well as dysmenorrhea. She had her last menstrual cycle about 34 days back, 4 days extra than expected. Underwent a previous surgery for incisional hernia. Now, on examination, she comes to you. She looks pale, and when you have examined, it is around 14 to 16 weeks gestation size, the uterus size, per abdomen, PV, everything put together. Bimanual examination said 14 to 16 weeks uterus size. Now, what are all the things that are running your mind when you arrive at the diagnosis of this patient, point number 1, the second question to you would be, what else would you do to come to the diagnosis and proceed regarding the treatment part about this patient? Next slide, please.
How much amenorrhea period? 4 months?
34 days.
34
34
days.
days.
34 days.
Totally 34 days. Dr. Kritika, are you there?
Yes, ma'am.
Dr.
Differential
Kritika?
diagnosis would be pregnancy or maybe adenomyosis or fibroid leiomyoma. And she might be bleeding because of anovulatory bleeding because of perimenopausal age group. And lab test would be a CBC, thyroid test, and sugar test, sugar HbA1c, ma'am, and would get her one
of anovulation.
And would get
Thinking
one would get one transvaginal sonography and sonohysterosalpingography if needed.
Yeah, MRI. If you think that TVS is not enough for you, then you may have to go to the MRI. But most of the times, the ultrasound is enough in our case.
Battery is low.
And in a proper center by a proper person.
Has to be done. The options we have mentioned. It doesn't mean that everything has to be done.
Yeah. Yes.
Yes, you can go with MRI. Yes,
Yes, madam. Next slide. Yeah, her urine test, because 4 days postponed, we checked and she was not so old also, 36. The UPT was negative because tubectomy was not done. Monica, Badakara, thank you. Ultrasound revealed fibroid uterus. Hemoglobin was much lesser. We started her on definitely on iron replacement therapy as the first line of treatment. Next slide, madam.
So what are we going to do? This is the general information. That's all.
Yeah, this is the general information, counseling, dignity, all that. Next. Yeah, the uterine artery embolization, one of the treatment, because she has multiple fibroids.
What they are going to treat, then you can tell the decision. No, now the patient has previous 2 years, one incisional hernia surgery, and now 14 to 16 weeks, and she doesn't want any surgery. So what are all the treatment you are going to do? You ask the panel.
Her clinical presentation was that much, Dr. Kritika. And definitely patient is young. She is not for hysterectomy. She is not pregnant. She has fibroid uterus. This is how she has presented to you. Now, how will you proceed with this case? Explaining her all the different possibilities.
Ma'am, because her HB is low, we'll ask her to take iron supplement and
you have given her. You have given iron injection.
Given one IV injection. Already given.
Yeah,
that is done. They have to map the fibroids, madam. What type of fibroid it is, a submucous or intramural or subserous. We have to map the fibroid. Then, because some fibroids, submucous and subserous, do not respond to your medical management. So you map the fibroid, then you can decide. And also an endometrial biopsy, you rule out because she is severely anemic, and then we can proceed with the definitive management.
Yeah, that we have mentioned in the previous slide, endometrial biopsy, because it's a hyperestrogenic state. And yeah, she is not interested in future fertility. Yeah, this is one of the options. Next slide, madam.
So
we are just covering.
Go with uterine artery embolization or not? It is a subserous and submucous as per your mapping.
Amla, madam, the question is to you.
Subserous and submucous, it won't do any harm for the patient. Except only thing, it will be growing. That too very slowly only. It won't produce any severe menorrhagia or something and severe pain. In this patient, she didn't complain of any pain abdomen. No?
He has menorrhagia and
dysmenorrhea. Dysmenorrhea was there because of the
so what is the
these are associated adenomyosis. If it is there or not, that also you should look for. No
adenomyosis, only fibroid. What is the type of management for her? She is not already 2 LSES and 1 incisional hernia. Now she is afraid of a surgery.
Not interested in fertility.
Can be attempted. Uterine artery embolization, you can try.
Yes, now even in the government hospital setup, we have the uterine artery embolization. For this patient, I think uterine artery embolization will be the best management.
And follow whether the size is coming down or not.
So if she is
Yeah.
affordable, this procedure can be done. I think that's all. This is the advantages with the no scar. And
Yeah.
Rekha, do you want to discuss this and we'll finish? I think.
Yeah, all of us know about this. Ultimately, it is like no surgery, but we want to conserve the uterus and make the patient relieved of her symptoms. So coming to all the combinations, because we have already discussed the medical treatment, we have discussed about the LNG. Now we are coming to the other methods, like what Madam has mentioned now. The advantages of the MRI would be no scar. Patient will, it is not a proper surgery kind. Like the hospital stay will be for a shorter time. The patient can resume her work and all those kind. But only thing is that you have to counsel, one, cost, two, that it may recur, third, the repeating of the procedure. So these are all the things that should go in part of this hi-fi kind of treatments for these patients. Yeah, thank you, madam.
Then this is the GCPR, our Fogsi GCPR. That also you can tell the. How many of you will
So
proceed
intramural or sub
acetate? Any panelists want to go with uliprostol acetate since the patient is not willing for surgery?
Anyway, role for me. Yes, madam.
Ma'am, uliprostol acetate, high liver toxicity, ma'am. So better we go for mifepristone in lower doses.
Mifepristone for 3 to 6 months.
How much milligram you will give mifepristone?
25 per day. 25 milligram per day for 3 months, madam, or 6 months.
Yes.
But you have to follow up with the blood parameters also.
So definitely this uliprostol and mifepristone is reducing the fibroid size. And for this patient, since she is not willing, you can go with the latest treatments of uliprostol and mifepristone. But always the patient's choice is best. If she is not willing, means you cannot compel the patient. That's all. I think we have finished all things. So finally, if she is coming again, means you can go with a myomectomy or gastrectomy. Thanks to the panelists. Always save the uterus. It should be our aim. Rekha, you can get one point from all the panelists and Ambuja madam, and we can finish it.
Yeah, thank you, Sampath madam. We have discussed about 3 important cases about the adenomyoma, fibroids, and all different clinical scenarios. Ultimately, what we spoke was on medical line of treatment, the surgical line of treatment, LNG, and the recent modalities of treatment. Ultimately, our presentation was aiming at, as Sampath madam told, the preserving of the uterus. That is why we were talking about all the different other kind of treatment. Now, I would like to have take-home points from each of our panelists. Dr. Sridevi, can I get take-home point from you? Dr. Sridevi is there?
Yes, ma'am, I am there.
I can't find her. And
Ma'am, I am there, ma'am. I am there.
Dr.
Ma'am, in
yeah,
AUB,
yeah, I know.
In AUB, in
Ashish is not there. Right.
Ma'am, in AUB, in almost all the cases, except in hyperplasia or in hyperplasia with atypia and malignancy, in almost all the cases, it is preserve the uterus. Either it is medical management or conservative surgery.
Yes, fantastic.
Yeah, but why not in hyperplasia? In hyperplasia also you
Hyperplasia
can, no?
with atypia. Hyperplasia with atypia.
Okay.
With
Fine,
atypia.
Fine.
Other hyperplasias, medical only.
Yes. Yeah, that's right. I don't think Dr. Ashish is there. He has left with the note. Anyway, so Dr. Ashish is not there, Dr. Sumaya? Dr. Sumaya?
She's also not there, I think.
Yeah, she's also not there. Dr. Sujata allegation?
Madam, it is hysterectomy should be the last resort for any case unless it is a pre-malignant or endometrial intraepithelial neoplasia. It should be a last resort. And then submucous fibroids, again, 0, 1, 2. Medical management, I think it will not work out. Better for a hysteroscopic removal. Yeah. And also the newer drug, elagolix, has come into market, madam. And we have to try also for when such cases, endometriosis, adenomyosis, I think it will give a better result. It is approved in developed countries. And it has also now come into our market. So we can have a think about that also.
Yeah. Yes. Thank you, Dr. Sujata. Dr. Kritika, please. Dr. Kritika, please give your take-home point. Please unmute yourself.
Amla madam is there. You asked Amla madam.
When a woman comes with the AUB after the 40 years, better you check the other comorbidities also, always. The hypertension, diabetes, thyroid, all those things sometimes may be the cause for this bleeding also. So better comorbidities. And then when the endometrium is more than, if you feel that it is thickened or hyperplasia there, nowadays they say that better you don't do a DNC, it is a hysteroscopic biopsy may help you. To the localized place, you can take that, no? Hysteroscopy biopsy will be a better option rather than simply doing a blind DNC.
Yeah, see and treat is always better because you get more information as well as a targeted biopsy. Thank you, Amla madam. Yeah, you are so right. I move on to Dr. Hemavati.
Perimenopausal AV is the most common cause for women visits to the gynecologist. So above 40 years, we have to treat, invariably they'll come with anemia. So we have to correct the anemia, whether it will be the medical management or a surgical management, so that the healing will be the better. And we have to follow the Fogsi CGPR. So medical management, I'm going with all other panelists that save the uterus. That's it, ma'am.
Yeah.
And we have, as Sambat Kumari ma'am said, cardiac unit is there in every hospital. So we can think about uterine artery embolization. It is available. Radiologist can do easily. In case if the multiple fibroids patient wants to, young age, submucous fibroid, we can do that.
Yeah.
Madam, in our hospital, we have done 4 or 5 cases of uterine artery embolization for they are coming with secondary PPH. After 40 days, 60 days, they come with severe anemia. And we have done, and it was successful also, and they have conceived also after that procedure.
Yes.
Yeah, correct. Yeah. Now, Dr. Lalitambika, you want to give the ultrasound part of input or any other? As you please.
Not ultrasounds. Actually, as all of you have told, conserving uterus is our aim. But when indicated, we should be willing to do hysterectomy also, depending upon the socio-economic and other considerations of the patient. Then coming to medical management, actually, I feel ormaloxifene is a little bit underused. Many people are not using ormaloxifene. I have been using it a lot. So really very good, especially even for big fibroids and bleeding. When you want to correct anemia, give ormaloxifene. It will produce amenorrhea. You can correct anemia by oral or parenteral iron and then take a definitive decision. So without much side effects, one of the medical management for AUB should be ormaloxifene. We should promote ormaloxifene more and more. And the practical thing is many a times we see patients coming after blood transfusion to us, even for 8 gram, 7 gram. So we should discourage such sort of blood transfusion for correction of anemia. We should make the patient amenorrheic, give iron, correct the anemia, discourage blood transfusion. That is one thing that we should tell.
Now we have that carboxymaltose also, FCM. That also can be used.
Yeah, FCM single dose you can give. Now, even now, many people are giving iron sucrose. So patient will take 1 or 2 and they will not come back. You can give FCM now. Cheaper preparations are available. So 1000 milligram can be given as a single dose. Better to avoid blood transfusion unless it is definitely indicated.
Thank you, madam.
As LNG has replaced hysterectomy, the iron, the FCM has replaced the blood transfusion in the present era. We agree with you, Lalitambika, madam. Dr. Kritika, you weren't there. Please give your opinion also.
Yes, ma'am.
We are talking about the take-home point.
Yes.
What would you give us
Most
as
of
a
the post-perimenopausal bleeding can be controlled with hormones or LNG IUCD most of the times. But patient has to be counseled accordingly, and patient has to be counseled so that they agree that it is not cancer and they'll be happy, and we can give them treatment. Counseling is the main part because mainly people come getting scared, telling it's cancer because people are scared of cervical cancer and endometrial cancer.
Okay, thank you, Dr.
Another one point, madam, when they come for management, better we have to screen for with pap smear and if possible for the vaccine. That's it. Sambat Kumari madam is very much interested.
Dr. Ambuja madam is there?
Thank you.
Expert, Ambuja madam?
Madam is not there anything.
Okay, fine. Yeah.
Thank you. Good, very interesting panel. Thank you, panelists and Rekha madam. Final word from Rekha and we'll finish.
Yeah, LNG.
Hi, Sampath. Hi.
Shobha.
Hi, how are you? Great panel discussion. Very nice. Rekha and Sampath both. Sampath, as always, very nice. And very vibrant also. All the panelists have participated. So good discussion. Actually, you know, saving the uterus is the motto, and gynecology has become very, very medical today. You know, Sampath, these EEBR which are coming up with Dr. Sunita Tendulkar's tenure, it is going to show us gynecology has become very medical. So, yeah, so very good messages given today. Congratulations. Very nice.
My one thing I just want to mention, my
Kamala madam.
professor Dr. May Manuel used to say, just because it is somebody's uterus, you can't remove it simply.
Yeah.
Yeah.
No. It is not a redundant organ. Even after childbirth, it has got a role. So
Only thing nowadays, the lifespan has improved so much, so that women are subjected to so much of complications. When they were living up to 50 or 40, there was no problem. Any no fibroid, no adenomyosis has increased nowadays. No, initially we were starting our practice, we didn't see any adenomyosis. Nowadays, every alternative woman coming to you for dysmenorrhea is adenomyosis.
maybe, madam, it is a better pickup with better quality ultrasound.
Maybe there, maybe
Also there. Yeah, there is better pickup rate.
Ultrasonogram, everything
Yeah.
has entered and
Correct,
diagnosed
correct.
in the early stage itself. No.
Yeah, yeah. And sometimes it is not the cause of bleeding. It may be an
Like-
incidental finding. May not be the cause of
Like-
bleeding.
Monica is going to forget.
Like
Okay.
PAS like Pazant-Akrita syndrome or isthmosila have come into our diagnosis basket. Probably adenomyosis is also added to our gynecology diagnosis basket. My take-home message is definitely saving the uterus, but make sure that the histopathology of the myometrium or the endometrium and the pelvic organs are
Those
normal.
normal findings.
Point number 2, that you have counseled the patient about all the different aspects, what we have spoken, like, and try to conserve the uterus with whatever, like the minimal invasive or LNG or medical treatment. Thank you.
Okay, thank you.
Thank you.
Monica.
Thank you, Monica. Thanks a lot.
Thank you, ma'am.
Thank you, ma'am. Thank you,
Thank
ma'am.
you.
Thank
Bye.
you. Thank you, Sampath Kumari ma'am.
For the-
Rekha ma'am.
Thank you.
Shobha Gudi ma'am. Thank you.
Thank you.
Thank you, Monica.
Thank
for the opportunity.
Dr.
We
Monica,
for the
you.
official
Also
vote of thanks.
Yeah.
I would like to thank Dr. Jaideep Town sir, Dr. Madhuri ma'am, Dr. Ajay Mani sir as the pillars of strength, and Dr. Kalyan Baramde. We would also like to thank Dr. Charmila madam, who has graciously accepted our invitation to be the guest of honor today. Our speakers, Dr. Ambuja madam, Dr. Shobha ma'am, Dr. Sampath Kumari madam, Dr. Rekha ma'am, and Narsimha sir couldn't join us due to an emergency. Our chairpersons, Dr. Archana ma'am, Dr. Umayal ma'am, Dr. Bharati madam, Dr. Vidya ma'am, Dr. Niharika, and Dr. Raghavendra sir. Thank you so much for joining us. Last but not the least, all our panelists, Dr. Sridevi madam, Dr. Hemavati ma'am, Dr. Kritika ma'am, Dr. Sumaya ma'am, Dr. Sujata, Dr. Ashish, Dr. Lalitika, and Amla Devi ma'am. Thank you for your excellent inputs. We also thank Corona Remedies for the academic platform, which is the 32nd episode. And Shobha ma'am, we have already conducted physical CMEs for Save the Uterus. By around
Wonderful.
AICOG, we should be finishing around 100 episodes of physical CME for Preserve the Uterus, ma'am.
Wonderful.
Today
Wonderful work,
was
Monica.
the 93rd program, ma'am.
Excellent, excellent. You'll hit the
And-
century, I think, before AICG.
Yes, ma'am.
Yes,
Yes, ma'am.
yes.
Thank you
And
so much,
we-
ma'am.
Bangalore also.
Yeah, correct.
We invited Dr. Barmade in Bangalore and Dr. Parag Biniwale, and we did a physical CME about Save
Yeah,
the
yeah. Save the
Monica.
Uterus we have done in Bangalore, yes. Very good. Very
Yeah.
good.
Thank you, Dr.
Excellent work,
Monica.
Monica.
Sampath
Keep it up.
madam.
Thank you all. Thank you.
Yeah, thank you all the panelists.
Thank you, ma'am.
so much.
Thank you.
Yeah,
Bye.
bye bye.
Good night,
Bye.
everybody.
Good night. Good night.
Bye bye.
Good night, everyone. Thank you, ma'am. Thank you so much. Thank you, Shatabdi,
Bye,
for
bye.
being the
Dr.
support.
Monica.
Thank
you,
you,
See
ma'am.
you all in
Madam,
AICOG.
Sampath madam, everyone. Thank
See you all in AICOG.
Yes, ma'am.
Yes, ma'am. In the
Bye.
Preserve the Uterus workshop, ma'am, on the 8th.
Ma'am, see you all in East Zone Yuva Fogsi at Shiliguri prior to AICOG.
Yes, yes. Yes, I'm coming.
पहले
Third
ISO
week
Niva
of
Foxy
December.
फिर ICOG.
Chalega,
Third week
Shatabi,
of
all of us are
December.
there.
Yes,
Yes.
Priyankur had told me.
Thank you.
Fine,
Yes, ma'am.
fine.
Yes,
Sure,
ma'am.
sure.
Yes, ma'am.
Thank you, ma'am.
Nice to see
Yes, ma'am.
you. Yeah, Monica, thank
Yes,
you so
ma'am.
much.
Same
You are
here,
in the.
ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Yes, bye. Good night.
Good night.
Hmm.